live now.
Yeah. So good afternoon, everybody. At the outset, I would like to thank IAGE and OXY for this collaboration on this fertility sparing surgery. Why, when, and how. So spare it to reproduce. This is a very important concept because we are seeing more and more infertile women with lots of pathologies. So we need to know how to maintain their fertility potential by making sure that we clear only the pathology without compromising on the fertility aspects. With that in mind, we have focused this particular webinar on fertility sparing surgeries in various scenarios. So, yeah, next slide, please. So Dr. Atul Ganatra, the president of IAG, is currently busy with some emergency, so he would join us a little later. So we start off with the invocation song. We seek the blessing of the Almighty to make sure that the webinar brings in quite a lot of knowledge and goodwill to all our delegates who are attending this particular meeting. Play it. So lighting of the lamp, I think we can skip this Sahiti. Yeah. So to start with, we have our chairperson, Dr. Vanitha, who is going to chair the first session. So Dr. Vanitha is a very, very vibrant endoscopic surgeon from Chennai. She is a teaching faculty of the Ethicon Institute of Endoscopic Surgery, and she is also the managing committee member of OXY, very active academician, and also she is an EC member of Tamil Nadu IAGE. She is also the South Zone Foxy Endoscopy Coordinator and have various other accolades. So now over to Dr. Vanitha to introduce the first speaker.
It gives me immense pleasure to introduce none other than our dynamic treasurer of OXY and managing committee member of IAGE and the founder secretary of TNIAG, Dr. Malaraj. A very, very dynamic, enthusiastic person. And she has won many awards, and fibroids are a fourth. And we're all waiting to hear from you on the fertility sparing surgery in fibroids, how, when, and why. Over to you, ma'am.
Thank you so much, Dr. Vanitha, for those kind words. So let me share my presentation. Oh, sorry. I think I've shared the wrong one. Wait. Yeah. So is my presentation visible?
Yes, ma'am.
Okay. So, fertility sparing surgery in fibroid is a very, very important topic because it is a very common condition which we as gynecologists and also as fertility specialists encounter in our day-to-day practice. Of course, we all know fibroids are monoclonal tumors, but only thing is when it comes to fertility, we need to really understand these fibroids at molecular level, the anatomical level, and also at the surgical level to appreciate why, when, and how one needs to remove these fibroids so that we improve her fertility outcome and not compromise on her reproductive outcome. So these are the kinds of fibroids which we keep encountering. As the days goes by, it is not just simple myoma or simple myomectomy we get to do. We get to do only complicated myomectomies. So we also need to be skilled to make sure that we are able to tackle all of them without compromise on any of the aspects. So to understand the fibroids, we need to know that there is quite a lot of light which is being thrown on the current understanding of fibroids, which states that it arises mainly from the stem cells, which plays a very, very vital role in the development of the fibroids. That is the reason the genetic factors and epigenetic factors have been highlighted in the fibroid development. Apart from that, we also need to understand that physical disruption of the junctional zone and also the changes in the expression of both the estrogen and the progesterone and the receptors it also affects the junctional zone, and these again affect the fertility of the particular women because they increase the expression of aromatase, changes the estrogen receptor predominance, and also causes possible changes in the progesterone expression even if it is not affecting the cavity. So that is the reason we need to understand the mechanism by which the fibroids cause infertility. So people think that generally only the cavity distorting fibroids will compromise on the fertility, but this clearly depicts how exactly the non-cavity distorting fibroids can also compromise on the fertility. That is the reason why intramural fibroids we need to remove. So how exactly they also affect is that they causes a reduction in the HOXA10 genes and the glycotyline levels, which are very essential for the implantation. So this have been compromised, and as a result, even if the embryo is going to come and get lodged in the endometrial cavity, it will be rejected, and as a result, she will not be able to conceive. So this is the vital reason why the intramural fibroids, even if they are away from the junctional zone, we need to remove. Again, the progesterone plays an equally important role as estrogen in the fibroid growth. The estrogen stimulates the junctional zone and induces uterine contractions, whereas if you see the progesterone antagonizes the effect of estrogen and suppresses the uterine actions. So in the presence of estrogen, the progesterones will be expressed more to allow the binding of the progesterone to the progesterone receptors. So why we need to do the fertility sparing surgery in fibroids? So for the non-cavity distorting intramural fibroids, they cause endometrial vascular disorders and inflammations, which causes a non-conducive environment for embryo implantation. And with the presence of intramural fibroids, the HOXA10 genes and the glycotyline are reduced, which hampers implantation, and also they cause disruptions or thickening of the junctional zone, which increases the uterine peristalsis and again cause implantation failure. There will be also causes high uterine peristalsis. It has been found that by Oshino et al., there is an abnormal uterine peristalsis, and this was categorized into two groups. That is a low uterine pressure, where the peristalsis of the uterine uterus was measured when there are less than 2 peristalsis in 3 minutes, and when there are more high uterine pressure is when there are more than 2 peristalsis in 3 minutes. So this they measured with the cine MRI to see how much would be the intrauterine pressure. So it has been found that all the patients in this particular study, they had the same number and diameter of fibroids, and the fertility treatment was offered as ovulation inductions and IUI. And the results were that 34% had a pregnancy with low uterine pressure and 0% had with high uterine pressure. So that once the fibroids were removed, all of these women were able to conceive. Again, the most important aspect in fibroids, what one need to understand is that of the pseudocapsule. The pseudocapsule is like a double-edged weapon. It has two effects. One is anti-fertility and other is a pro-fertility effect. So it contains bundle of smooth muscle cells and neurotransmitters. It is highly vascular to supply blood to the myoma and also allows new vascularization. So, however, it also alters the uterine pressure. And this is due to the neurotensin and neuropeptide and also the thyrosin, which are present in the pseudocapsule. So, that is the reason why once the fibroid is removed, the women is able to conceive. But apart from that, it also has a pro-fertility effect. That is, although the neurotransmitter produced by the pseudocapsule, they induce the uterine peristalsis. They are also important in promoting inflammations and proper wound healing. So it is mandatory to perform the intracapsular myomectomy to enhance wound healing, reduce the blood loss, and also enhance better wound healing, correct the muscular anatomical correction should be done to preserve the fertility potential. Apart from that, the steroid hormones and the growth are also responsible for the growth of the fibroids. And it has been found that the women who have been treated with only estrogen or progesterone, they had a smaller volume of fibroids compared to those who are treated with both estrogen and progesterone. So, which means that the progesterone were also mandatory for the growth of the fibroid. So, when non-cavity gestating fibroids needs to be removed? So this is a constant dilemma for us. It has been found that there is a reduction in the pregnancy rate even with small intramural fibroids as small as 2 centimeters. And also there is another study where they found that fibroids more than 4 centimeters have adverse impact on the pregnancy outcome since they require more ART cycles. Now, does myomectomy improve the pregnancy outcome? So this is a study by Bulletti et al., where he showed that there is a higher pregnancy rate and also birth rate post-lap myomectomy. And also Campo et al. Reported significant improvement in the pregnancy outcome post-myomectomy in subserous and intramural without undergoing ART procedures. So the delivery rate also was improved from 38.5% to 86.2% post-surgery, while the missed abortion rate was reduced from 61.5% to 13.8%. So these improvements were due to the impaired fertility due to the altered uterine peristalsis and the blood supply. So Ashina et al., he reported that women with increased uterine peristalsis demonstrated by CT-MRI prior to surgery had increased pregnancy rate due to normalization of peristalsis, and the pregnancy rate was low when the fibroids were 5 millimeter less away from that of the endometrial cavity compared to those that were more than 5 millimeters away. So this post-myomectomy, the pregnancy rate were found to have improved by 57% and also in another study by 49%. So how do we perform this fertility sparing myomectomy? So this is exactly the principle that we need to follow while doing a fertility enhancing procedure, wherein we have to make sure the first most important thing is we should not damage the myometrium, for which you can see that I have injected vasopressin onto the uterus, and then that is outside the fibroid, and then we have to enucleate this fibroid slowly. So this vasopressin has to be injected at a dilution of about 10 units in 100 ml. You can even go up to 40 units in 400 ml. And the most important thing is that the vasopressin have to be injected outside the pseudocapsule and not into the substance of the myoma for better hemostasis. A small breach in the endometrial cavity, however, would not compromise on the integrity of the scar, and but only thing is we have to make sure you suture the myometrium in layers so that the wound heals better after the surgery. So you can see that the entire fibroid is now removed, and then we have to suture it in layers. So 2 or 3 layer suturing is all that is needed. With the advent of barb suture, suturing has become really comfortable and made all our life quite easily. So this is now where how you suture with the barb suture. Here, this particular has a loop, so you can just railroad it and just keep continuously suturing it, because the barbs has the ability to anchor the suture. There is no need for an assistant even to follow the suture. And also the most important advantage is that it produces uniform tension on the suture line. As a result, it does not cause any kind of a necrosis on the tissues. So as a result, it does not interfere with the healing. And also it is found that compared to the smooth suture, these are better, because the smooth sutures like Vicryl, we have to, when we are throwing knots, it has been found that the knots have been found to be the most weakest point, because they of the suture material which is present, and the next weakest point will be the area adjacent to the knots. So because of the absence of, the less suture material on the suture line, the barb suture seems to be scoring over that of the smooth sutures. So once you finish the suturing, you can see a very clean scar like this. And finally, we also need to make sure that we morcellate them inside the bag, so that we do not leave any kind of bits and pieces in the abdominal cavity. And as a result, you can prevent, so all the disseminated tissues are confined within the cavity, and you will not be worried about any kind of parasitic leiomyoma in the post-operative period. Sometimes when you have a little larger fibroid like that, we can do a intermittent suturing, which would be much better, because this helps us to bring the myoma, both the flaps together. So this is a huge intramural fibroid which has gone into the endometrial cavity. So many times we can see that the fibroids are once removed from the myometrium. Even if it is not disturbing the endometrial cavity, the women are able to conceive. Even if they have gone into the endometrial cavity, we have to just suture it in layers, so that the wound heals better. So here you can see that the entire myoma had gone inside the endometrial cavity. So we are just enucleating it, and finally suture. There's no need to suture the endometrial cavity. We have to just bring both the flaps together. So together, this is a box stitch which we utilize to get the both the flaps together. So once both the flaps are brought together, we have to make this is mainly to ensure that there is no dead space. So dead space is one thing we have to really avoid, to make sure that you do not have any kind of a rupture of the uterus when she gets pregnant. So for this, we have to employ this kind of a technique where you can get both the flaps together, and you can keep suturing it in layers. So this is the suturing of the myometrium in layers, and can again use the barb suture to suture it. And finally, you can use the baseball stitch. The basic advantage of the baseball stitch is that it is an in-out technique, where you can get the raw areas together, so that there is no exposure of any raw areas, and thereby you can prevent adhesion formations. So here you can see that the raw areas are completely brought together, and they have gone inside, and you will have a very clean suture line. And finally, we can just morcellate it inside the bag, and then make sure the whole, all the bits and pieces are removed completely. And placing an intercede over the suture line is a good idea to prevent adhesion formation. But only thing is, we have to ensure that there is no bleeding at the end of the surgery, so that it plays the role of adhesion barrier and not a drag adhesion. So the most important thing, we also need to make sure that we suture the port site, so to prevent the development of the port hernia. So this is a multiple fibroid. So sometimes when we encounter multiple fibroids, like multiple small fibroids, again, it becomes a problem because think my system is getting hanged. So this is uterine artery ligation at origin. So here you can see that the uterine artery is being skeletonized and is being skeletonized, and you can just ligate the uterine artery temporarily and finally remove it at the end of the surgery. So here, this is a shoelace technique, and you can just remove it at the end of the surgery. And sometimes you can also just string these myomas by taking a string like this, so that you can park them safely while doing the procedure. So finally, at the end of the procedure, you can just pick them up and put it inside the bag and modulate it inside the bag. This is the stringing of the myoma, so that you do not lose any myomas at the end of the surgery. So here, this is the stringing of the myoma. You can see that as we are removing the fibroid, we are stringing them and parking it on the anterior abdominal wall and then putting them inside the bag. So sometimes we also encounter these, the fibroids which are looking totally degenerated. Again, we have to follow. The most important thing is our technique should be intracapsular myomectomy, so that we leave behind the pseudocapsule. So as long as the fibroid is there, the pseudocapsule is going to be determinant. But once the fibroid is removed, the pseudocapsule helps in healing of the wound, and it is going to be pro-fertility for these fibroids. And you can see that again, you can do an in-bag modulation for this. This is also another technique of in-bag modulation, where you can use a Lima's bag also. So that was a more safe bag. So this is yet another technique. And finally, we also check the integrity of the bag. Sometimes even the submucosal myomas, when you have a plethora of them like this, we can also remove them laparoscopically. So this is a plethora of fibroids which were removed laparoscopically, almost 15 of them inside the submucosal cavity. So this is a laparoscope which has been put inside the endometrial cavity, and the fibroids are now being removed, and then finally we are modulating it. So sometimes the cystic fibroids like this can also create problems. So as a result, in these cases, rather than the standard technique of retraction and traction and counter traction, this involves quite a lot of dissection. So we have to dissect these fibroids from the base and enucleate these fibroids, and finally it is a must for these cases to be modulated inside the bag, because these are cystic ones, because there'll be fraying of the tissues all over otherwise, and you'll have a dissemination. So this is again an anterolateral fibroid, which again when she was a gynecologist, and again once the fibroids were removed, the doctor was able to get pregnant. So this is again the uterine artery ligation. Again, we have already seen that. So the risk of rupture occurs only when you compromise on the surgical principle. That is, when you leave behind the dead space a lot and then use a lot of energy sources, thereby traumatizing the myometria. And also when your suturing is not appropriate. Okay, so when it is too loose or something. So all these things are the reason why you have a uterine rupture. It is not just because of the opening of the endometrial cavity. So it is the myometrial damage which results in rupture. So these are the various literatures. And for uterine rupture, the reasons why you have the uterine rupture is highlighted here. So to conclude, fertility sparing surgery for fibroids does improve the reproductive outcome, provided one follows the fertility enhancing surgical principles. So I would like to thank IAGE and OXY for this opportunity. Thank you so much.
A very nice lecture, ma'am, with a wonderful collection of videos and a wide range of cases. Is there any place where you do a serum LDH, ma'am? And if your serum LDH is high, how do you go about?
Yeah, so only when we are suspecting it could be anything other than the fibroid, like, leiomyosarcoma. But most of the time, like even if those things are showing normal, we can still encounter a leiomyosarcoma. But so it is not very diagnostic. LDH isoenzyme 3 is what has been suggested. First, it is most expensive, modality. And again, the thing is, it's not available with all labs. If you ask for LDH, they will just do the simple LDH and not isoenzyme 3. So that is one biggest problem. But then again, as I mentioned, it cannot be just very specific for this particular condition. So in certain situations, if you're really in doubt, you can still do, but still the diagnosis of leiomyosarcoma comes only retrospectively, post-operative diagnosis. So to some extent, at least to save our skin and to make sure that we have done everything for documentation, it is always better to do that.
When do you go and interfere with recurrent myoma? See, you operate and then within 2 years, she throws up another fibroid and she has 1 or 2 failures after transfer. Do you go mandatorily remove them, ma'am?
Yeah, so more than 2 years gone by, and if she is again developing a fibroid, I prefer to operate because again, see the very fact why she has not conceived after the first myomectomy. Seriously, we don't know. So we need to know exactly what was the reason for her failure of pregnancy, whether it was implantation failure or poor quality embryos, all those things we should look into. If it is a poor quality embryo, then we will not be in a hurry to remove these things. But if the embryo quality is good and still she has not conceived, then maybe we can, that time we can attribute it to the recurrent fibroid. So we do not want to, risk her with another failure. So in such situations, rather than going with, like you, maybe the 2 year period, definitely we would have tried all, medical management, like GNRH analogs and all that. But still, in spite of that, I think I will give a time frame of about only 2 years because age is now becoming a very major factor because most of these women, they are also starting late. So in such a situation, I would prefer to definitely remove these recurrent fibroids.
For the size?
Pardon?
Do you have any cutoff on the size to see?
Basically, anything like suppose if they are going to distort the cavity, then size is not the factor. Any size you have to remove it. But if it is not distorting the cavity, the fibroids of more than 4 centimeters, I prefer to take it off.
We all know of late you're getting used to the hysteroscopic oscillator. Does that have an advantage over your resectoscope?
Yeah,
The med-
definitely no. So because hysteroscopic modulator, the basic advantage is that it does not damage the basalis of the endometrium. So because it does not damage the thing, the fertility is not compromised, and the women can start, like you can even transfer the embryos immediately. Also, you don't have to wait for at least 3 months after the resection. I mean, after using the resectoscope. So that is one basic advantage. There's no damage, and also your transfer can also happen later. So it is a good one. But only thing is we need to, know the limits. Sometimes, like you may have to do it in a 2 sitting also if it is a large myoma.
I think there are no questions from the audience. That's the reason
Yeah. Actually, we are also having a quiz. So yeah. So can we have the so some multiple choice questions we have prepared so that like it will be quite interesting for the participants also, and there's also a prize for it. After each and every session, there will be 3 questions. So with multiple choices, so you can choose the right one, and the one who gets the maximum number will be the winner. So we have 4 prizes. So. Shantini, can you
Yes,
just
ma'am.
say the
Yeah. After reading the question, we will give 30 seconds time to answer. Yes, ma'am. Shall I launch first question?
yeah, please launch. 30 seconds, you will time it, okay?
Yes, ma'am. I request you to please read the question once, ma'am.
Yeah, so the pseudo capsule needs to be retained while doing a myomectomy as it helps in choice A is prevent recurrence of fibroid. Choice B is helps in reducing the blood loss. Choice C is helps in healing of the wound post surgery. So you can choose the right answer. 35 minutes.
Yeah.
So
Last 5 seconds. Timer.
okay, fine. Second question, please flash. So permanent uterine artery ligation or origin should not be done in fertility patient as it interferes with the healing process. Choice A. Choice B is reduces the ovarian reserve. Choice 3 damages the ureter. So time starts now.
Five more seconds. Timer.
Yeah. So
Third
one
question.
third. So when a patient develops complications due to vasopressin, we should not give A, atropine, B is vasopressors, and 3 is antibiotics.
Five more seconds. Time up. Yes,
Okay,
ma'am.
so all the 3 questions are over. So the result for this particular session, we will announce only at the end of all the 4 sessions. And we are very thankful to Shield Pharma for sponsoring this particular event and also for the prizes. So please stay back to know the results. At the end of the 4th talk, we will release the prize. Okay, so shall we move on to the next session? So the next speaker, Devan Jogal, has joined.
Not yet.
Just received a phone call from Devin.
Oh.
He's little late, so I will take my session first. And
Okay.
then he will join. So he will take my session.
Okay. Yeah. Yeah, Sahiti, can you please display Dr. Sujal Munshi's CV? Yeah. So, Dr. Sujal Munshi is a very, very renowned endoscopic surgeon from Ahmedabad, and he is the current Joint Secretary of IAGE, a very prominent position in IAGE, and he has the credit of performing over 20,000 surgeries and handling high-risk pregnancies as well. And he is an executive committee member of the Children University Gandhinagar and executive committee member of Department of Human Genetics and Zoology in Gujarat University, and also the chairman of Healthcare Task Force Gujarat Chamber of Commerce and chief faculty of Oxy, IAG, ICOG approved training at his hospital, and also the organized joint secretary of the annual IAG 2019 and Endo ATM. So over to Dr. Sujal Munshi for another very, very important topic. So we are seeing more and more girls again also having prolapse uterus. So most of these time, these girls, they have problem with their connective tissue. So as a result, they are not also able to hold on to the pregnancy and also not able to conceive. In such a situation, our fertility sparing surgeries are going to help. So let's hear from Dr. Sujal Munshi about the fertility sparing surgery in prolapse.
I'm especially thankful to Mala Madam and the whole team for organizing this wonderful event on a very specific topic of fertility enhancing surgery. And let us begin my talk with this. Usually we don't come across this situation very commonly, but there are instances where we have to do a prolapse surgery and offer conservative options to this patient, especially those who are nulliparous prolapse and they are willing to have pregnancy in future. And second is some special group of patients where they have previous bad obstetric history, especially obstructed labor and IUD, which may be the cause for her prolapse, sometimes prolonged labor, instrumental delivery, difficult labor, and complete perineal tear. So these are the patients where in spite of previous childbearing, this desire further childbearing, and we have to offer options where fertility is also spared and they don't have any issues while conceiving as well as while delivering. So in all these patients, thorough assessment is very, very, very important, especially to understand the etiopathogenesis. You may sometimes require help of MRI, but most of the times clinical assessment and a simple 2D sonography is sufficient. You also need to discuss with the patients about the available options. What are the pros and cons of each? What would be the implications of each procedure on fertility, future fertility and future childbearing? And you also need them to understand the implications of chosen method on this particular area. So first and larger group is the nulliparous patients, and they are very different from normal patients. Those patients who had previous obstructed labor or difficult labor and then they've developed this, they have good tissues. But the patients who have not had any previous deliveries but have has developed prolapse, there is an intrinsic cost, and most of the times it is because of the neuronal cause, or it is because of the tissues which are at defect, mainly the connective tissue and sometimes the muscles. So in these patients, we have to take different routes, but most of the times the management remains same. So conventionally, for more than 4 or 5 decades, open surgeries were being performed in all these patients. Vaginal surgeries have very limited role as far as nulliparous patients are concerned. Vaginal approach is still good for patients with vaginal hysterectomy and AP repair or sacrospinous. But for nulliparous or patients desiring fertility in future, most of the times we go for open surgery, or for past 3 decades, the laparoscopic surgery is taking over in most of these patients. So when you look at overall incidence of pelvic organ prolapse, it is from 2.9 to 41. And the areas which we rely on this is sacral promontory, which has been used for more than 2 decades now, the pectineal ligament, the Cooper's ligament. Sacrospinous is usually not used for fertility sparing surgeries, and sometimes we also use Cooper's ligament when there is associated stress urinary incontinence. So while laparoscopy in such cases, because we can access all the compartments equally, we can very safely use prosthesis, especially after the controversy of FDA, where they have banned vaginal meshes in most of the cases. Now, when you want to use prosthesis, it goes hand in hand that there should not be any opening in the vagina to avoid any infection and future complications. The treatment of incontinence can simultaneously be offered. We are switching over to conventional birth colpo suspension by laparoscopy in most of the cases. So this is also an advantage of laparoscopy, where without using any synthetic mesh, you can also offer treatment for incontinence, and you have all the advantages of minimal invasive surgery, like fast recovery, less infection rate, and when prosthesis is used, this becomes even more important. So another advantage of laparoscopy is the understanding of the pelvic anatomy. It becomes very, very, very important to understand all the supporting structure, and what can be better than a laparoscopy. By laparoscopy, you have a very good view of the pelvis under magnification, and with better camera systems available now, you have better definition of these tissues, and just by visual appeal, you can differentiate the tissues like paracolpus from bladder tissue, or ligament from paracolpus. And here the anchoring becomes very, very, very easy. And all 3 levels can be dissected: level 1, uterosacral and cardinal; level 2, endopelvic fascia and arcus tendinous are very well visible from laparoscopy. And even with good dissection, you can reach the perineal body also. So, but for most laparoscopic procedures, the area of interest is pubocervical region and rectovaginal septum, especially when you are preserving the uterus. Here, most of the surgeries which are proposed now by laparoscopy, the idea has evolved from major surgeries which were proposed by open procedure previously by some of the stalwarts, and very proudly we can say that majority of them were designed in India itself. So we will not go through details of all the possible procedures, but few important procedures which can still be performed laparoscopically is one of them is Shirodkar sling, or we can use modification of Shirodkar sling, which can be performed by laparoscopy. The major advantage is it is a very robust correction. The sacral promontory works as a good supporting system. The little disadvantage is it is a technically challenging procedure, especially when you make this hitch in the psoas muscle and go behind the sigmoid colon. Sometimes there is a possibility of bowel obstruction, and there is constipation also. But all sacral promontory corrections that are being done now with laparoscopy adapt few principles from this surgery, and this is going to stay for a longer time. Second surgery that we can offer is Purandare, and somehow in this sling, we don't have any other option but to offer a open surgery because you need to dissect the sheath, and the sheath is taken out through the broad ligament and hinged anteriorly. So the advantages of this procedure is it is technically very easy. It gives dynamic support because it is hitched with the anterior adductor sheath. With each cuff or any increased abdominal pressure, the uterus is diverted anteriorly, and that will prevent further descent. The recurrence rate is slightly higher compared to sacral promontory or any other route, but this can be offered very safely to nulliparous patients where future fertility is to be preserved. Another sling which was proposed was Khanna sling. It is a static neutral sling, and you can do a unilateral sling also. But since the tape was very superficial, there were certain cases where mesh erosion and infection was visualized, and then it did not become very popular sling over a period of time. So the conventionally what we use now is sacral promontory or pectopexy. And if you go back to the history, the idea of using sacral promontory came from the vault prolapse. But same thing was adapted for nulliparous prolapse, and it worked out very well. So if you go through older publications, they way back in 1957, and the earliest laparoscopic publications date back to 1994. Now, this is what they used to do in French technique. The publication of 1974, where they used inverted Y-shaped mesh, where one stem was between the bladder and the vagina. So vesico-vaginal plane was used, and it was encircling the uterus through the broad ligament windows. And here in front of the sacral promontory, it was tied. So the whole uterus with cervix was lifted up, and with single sling, the correction was carried out. So same technique was adapted by Clemofera group, and they had initially published cases of vault prolapse, and same technique was adapted for nulliparous prolapse also. So this is what happens in nulliparous prolapse. The uterus with cervix and vaginal tissue goes down. So to correct, we have to dissect between the rectovaginal space, attach the mesh there, and with that mesh needs to be attached to the sacral promontory. If there is cystocele, a window can be created, and you have to encircle the mesh, and it has to go anterior also. But before using this sacral promontory as an anchoring point, you have to understand the anatomy of sacral promontory, which is very important because it is completely surrounded by certain vascular structures and important vital structures. But what we are using, we don't use the periosteum, but anterior longitudinal ligament is being used to anchor the uterine organs, because it is a very robust structure, and it can take weight of 12 to 14 kg. And when you pass a stitch from that, and if you lift, the whole patient gets lifted. So it is a very strong structure which is used, but it is surrounded by certain vital organs. You can see the aorta getting bifurcated. Yeah, the common iliac is bifurcating, and external iliac is just on the right, and you have this internal iliac vein also lying nearby. You have ureters very nearby to this structure, and many a times you have a prominent middle sacral vessel. So especially when pneumoperitoneum is there and you have positive pressure, sometimes the vein, especially the left common iliac vein, is not visible. So you have to be careful about the anatomy. You have to understand the anatomy before this point is used for anchoring. So what was the principle of conventional surgery? We first dissect the vesico-vaginal space, same as we do in a laparoscopic hysterectomy. The extent of dissection depends on amount of cystocele. If you have a large central cystocele, you can dissect just about till just above the urethra. If you have more of lateral cystocele, then you have to dissect the space of Ritzius and do a para-vaginal correction. Now, after dissection of the vesico-vaginal space and both the round ligaments, second is the dissection of the sacral promontory. So you lift the peritoneum, you open the peritoneum above the sacral promontory, you identify the glistening white surface, which is anterior longitudinal ligament. You identify any medial sacral vessel or prominent vessel, you can coagulate it, but be very sure about the sacral promontory. After that, the same dissection is followed on the uterosacrals and the dissection in the rectovaginal space is being carried out. So exactly in the midline, the rectal pillars are there. So you dissect more laterally, and the extent of dissection can be up to levator ani if you have large enterocele. If there is no large enterocele, you can just dissect the rectovaginal space to an extent where you can attach the mesh. Now, once the dissection of vesicovaginal space, rectovaginal space is over, the levator ani is over, and you have already dissected the promontory. Now it is time for mesh fixation. So we used to fix the mesh anteriorly at the level of isthmus, and lower end of the fixation depends on the extent of cystocele. The anterior mesh from both the sides through the broad ligament window are taken back. Now here major concern was related to the vascularity of the uterus. So be very careful to preserve the uterine arteries. Always go lateral to the uterine arteries, and you need not to tighten the mesh around the uterine artery. So this was the concern, especially in nulliparous patients, where after the uterus becomes gravid and it starts growing, does this mesh affect the growth of the child? No, it has been proved by studies that the moment pregnancy takes place and uterus starts growing, the mesh is pushed down and the uterus starts bulging above it. So a lot of babies have delivered after this treatment, and the mesh does not come in the way. Neither the pregnancy badly affects the outcome of the pregnancy, and the vascularity is also not compromised. So upper end of the mesh is fixed with the promontory. The only disadvantage is in cases of extreme obesity, it is difficult to reach there. With previous bowel surgeries, it is difficult to reach the promontory. It has a little steep learning curve, and you have to be well aware with the technique. And because you are retroverting the uterus after correction, the anterior compartment gets opened up, and these patients might develop SUI, especially those patients who have history of prolonged labor. There is occult damage to the urethral supporting system. Here, the subclinical SUI will get converted into SUI, and you will need an additional corrective procedure to correct it. And second is constipation and bowel fullness. Anyway, this is a common problem in pregnancy, and those patients who have undergone this surgery might suffer a little more severity of this pain. And many a times in these patients, when you have some nerve entrapment, patient will have chronic back pain, and pregnancy becomes sometimes difficult in such situations, and you sometimes have to take out the threads which was anchored at the level of promontory before the pregnancy can be planned. Most of these cases don't have recurrence because mesh is already fibrosed and fixed. So even after removing the stitch, these patients never had recurrence, but additional surgery was required. And with promontory fixation being done with staplers or metal devices, sometimes they have very bad back pain, and that should be avoided. This was a case where a patient had chronic back pain, where metal staplers were used, and this should be avoided in nulliparous patients. Second common complication is when structures are not very well visible, and if proper dissection is not done in the promontory, especially on the left common iliac vein, injury is common. So you have to be careful about these complications, and an alternative sometimes is required. So now once again, for alternative, the pectineal ligament was proposed, and one of the largest study came, or one of the first few studies came from India itself in Pune. Initially, this was also proposed for Volt prolapse, but then the same technique was adapted for nulliparous prolapse in India as well as in Germany. And now very good results are there for past 7 to 8 years. Here, instead of using sacral promontory, what we use is pectineal ligament. So in pectineal ligament, the advantage is, if you assume this patient in standing position, the uterus is in more physiological position compared to any other anchoring point. If you attach it with the sacral promontory, it would be retroverted. If you attach it with Cooper's ligament, it would be extremely antivergent. But pectineal ligament is exactly in the line with the normal uterine contour, and that is why it is more physiological, especially when future pregnancy is desired. So this is how the anchoring takes place. Initially, we were using anterior mesh, but with anterior mesh, it was not physiological. There were incidences of retroversion of the uterus, and at the time of delivery or a planned C-section in these patients, the mesh would come in the way. So now we have switched over to posterior approach, and it works very, very, very well. Only thing is, even in this area, you need to be very careful about the anatomical structures which are surrounding it. There is in 30 to 40% cases aberrant collateral develop, and that is known as corona mortis, which is anastomosis between the inferior epigastric vessels and the obturator vessels. So, sorry, not or sometimes directly the external iliac and obturator vessels. So while dissecting on the pectineal ligament, you have to be careful about this vascular anastomosis. But pectopexy has advantages. It is a little away from the vital organs except the external iliac vessel and corona mortis. It is simple, effective, relatively fast, and it does not worsen the subclinical urinary incontinence because it does not open up the anterior compartment. So now let us go through the surgical steps. In a nulliparous patient, what we do is first we dissect on one side. This is on the right side where the assistant surgeon is holding the round ligament. I'm holding the obliterated umbilical artery. It takes not more than 1.5 to 2 minutes to reach the pectineal ligament. The first glistening structure which comes across is pectineal ligament, which is bounded laterally by external iliac vein and below by obturator fossa. So you need at least 2 to 3 centimeters of clear area so that you can apply the mesh very well. Once you dissect the 1 centimeter, it is time to further dissect the areas, visualize the structures. You can see here the vasculature, which is aberrant vessel between external iliac and obturator vessels. The same dissection is done on the other side. The advantage of pectineal ligament dissection is it is a bilateral correction. So even if the one side fails, you still have tissues anchored with the other side, and so chances of recurrence is less. Just like anterior longitudinal ligament, even pectineal ligament is a very strong structure, and it can hold up to 13 kg of weight on its own. So same dissection is being carried out. You identify there is no abnormal vasculature. Once you have dissected both the pectineal ligaments, now the dissection is carried out from one round ligament to other round ligament and in the vesicovaginal space, depending on the amount of cystocele. If there is no apparent cystocele, we don't push and we don't put any anterior mesh, especially in nulliparous patients, to avoid any mesh related issues. We also want to avoid the mesh which are encircling both the uterine arteries here. So what we do is we prefer a posterior mesh only when we don't have too much of cystocele. And here, after identifying the uterine vessels in the broad ligament, a window is created lateral to the uterine vessels. So the vasculature does not get affected. And once window is created, the ureter will get lateralized. There is no chances of kinking of the ureter even in after the uterus becomes harbors a pregnancy. And second is same window is created on the other side so that mesh can go posteriorly after attaching it with the pectineal ligament. A little amount of dissection is required in rectovaginal space to cover the mesh once it goes posteriorly. And if patient does not have any enterocele, you need not do dissection till the levator plate. This dissection is carried out till both the windows are visible. The mesh is taken out from posterior to anterior, and then it is fixed posteriorly, and on both the sides, it is fixed with the pectineal ligament. This correction is very important. So once you fix it with both the sides, you see vaginally how much the uterus has gone up. If at all you feel that further correction is required, you may do shortening of the mesh to perfectly correct it before you close the peritoneal defect. So now the advantages in nulliparous is you are not relying on patient's own tissue. You are using pectineal ligament. You are using a soft polypropylene mesh to induce fibrosis. You are taking posterior approach and you are preserving the uterus. You are not compromising the uterine blood vasculature for future childbearing, and you are not giving any encircling stitch or mesh surrounding the lower segment so that the growth of the child does not get affected. So long-term results with this technique is still awaited, but whatever short results are there, patients did not have any recurrence. Patients after surgery did not develop SUI. The chances of constipation is also less. Dyspareunia is also less. So this is emerging as a preferred procedure for nulliparous prolapse because complications rate are almost at par with any other procedure. So one more thing, in lot of nulliparous prolapse, simultaneous rectocele has also been found, and if it is there, it should also be corrected. Especially if it is enterocele, you have to take a stitch and go till the levator ani, and all this correction is in posterior compartment. So most of the times, while electively delivering the child with C-section, this mesh or posterior mesh attached to the lower end of the levator ani will not come in the way, and it will prevent long-term recurrence also after pregnancy and delivery. But in few cases, especially those who have developed iatrogenic, or we cannot say iatrogenic, but those who have developed prolapse after prolonged labor, instrumental delivery, and other things, they have simultaneously developed paravaginal or you can say lateral cystocele as well as SUI. So in all such cases, you have to offer very safely paravaginal defect correction or a simultaneous surgery for stress urinary incontinence, where from space of Ritzius, you can very well access the Cooper's ligament, which is actually the medial extension of pectineal ligament. So you dissect the Cooper's ligament, identify the corona mortis, you dissect the obturator muscle also, and tendinous arch. And then once you completely dissect this, when you identify the bladder, the most defective portion or this thing can be anchored very well with the Cooper's ligament. This was a patient of SUI and a lateral vaginal defect. So here we are anchoring the Cooper's ligament with the paraurethral region to support the mid-urethral mobility and correction of the angle. So once you anchor it with 2 or 3 stitches on each side, you correct the stress urinary incontinence. And if there is lateral cystocele, that also gets corrected when you go little more lateral. So you can see the amount of robust correction that is being done in such cases with simple laparoscopic procedure without using mesh. And at the end of the procedure, you can do a cystoscopy and identify any accidental passage of thread or accidental injury to the bladder tissue. Avoid over correction to prevent retention of the urine. Only slight correction is required to change the angle, and then rest of the things will be followed by fibrosis. And you close this defect. So quickly going through the after effects. Pregnancy after pelvic floor, when you go through very old literature where open surgeries were being done, where a lot of cervical amputations were being offered or vaginal surgeries were offered, the incidence of recurrence of prolapse was very high. And they said that even if C-section was used in this particular study, where more than 123 patients were studied, they said even after C-section, the recurrence rate was very high. But this changed over a period of time. The few studies or few recent studies, they have very clearly shown that laparoscopic hysteropaxy is a very safe procedure, and cesarean section is probably the best option to deliver in such cases, though there are reported cases of normal delivery and there was no recurrence. But still, most of the literature supports elective C-section in these patients, and mesh does not come in the way, especially when you have used the posterior approach. And subsequent pregnancy does not seem to compromise the hysteropaxy result. Even the Australian guidelines for uterosacral ligation and sacrospinous hysteropexy. They also suggest that vaginal approach is not one to be used, or still only uterosacral ligament hysteropexy is not very effective. If you want to offer a good sacral promontory or a pectineal ligament as a supporting structure. So for all this patient, site-specific repair is required. Soft Prolene mesh should be used. Sound knowledge of anatomy of whatever anchoring point you use should be used. Pectineal ligament is coming up as a very promising alternative to sacral promontory and should be thoroughly evaluated. And pregnancy does not seem to adversely affect the long-term outcome of these reports. Thank you very much.
That was such an excellent presentation, Dr. Sujal. Very, very elaborate and in-depth knowledge on the prolapse and why we need to, take care of them. Because recently also I had a patient who was hardly 23 and she had a second-degree prolapse. So in such situations, unless and until we address all these at a very early stage, they, end up going somewhere and losing their uterus, okay? Because standard, treatment is now hysterectomy only. So unless and until you have the skill of, doing a laparoscopic repair, we end up losing many uteruses. So in the last 2 months, I had 2 patients with these in the young girls. So this is a very, very important topic, though it is very rare. The incidence is less, but then it is an important one. But what I want to know is, suppose if the girl is having a congenital elongation of the cervix, in such a situation, what would you, along with that, she's also having the descent. So in such a situation, what would you suggest for her?
If there is simultaneous descent also, we have seen that this congenital elongation is start point for any prolapse development. So if you feel that after correction, laparoscopically correction of this defect, the cervix goes inside the introitus, then in that case, amputation may be avoided. But when you feel that it is so much elongated that it comes out of the introitus and it is affecting the fertility in other ways because of intercourse and other things, in those cases, after counseling the patient properly, a partial amputation can be offered to these patients. We have to counsel the patient that there are chances of the premature delivery, and you might require a procedure, something known as cervical encirclage during the pregnancy. But yes, if it is grossly elongated, you can counsel the patient and go ahead with the conventional methods, Fothergill's or Manchester method, simultaneously with the apical correction.
Yeah, correct. Very nice. So that is what. So only during the time of surgery, we'll be able to really assess, how much would be the, because we have to literally pull up the uterus and see whether the descent is still there, elongation is still there. So that is very, very important decision making. So counseling plays a very vital role, as you have highlighted. Suppose if there is a central cystocele along with the descent, no lateral cystocele, just a central cystocele. In such a situation, what would you do?
If it is only central cystocele, you may offer a vaginal surgical correction also. But if at all you go ahead and offer a laparoscopic correction, you may not excise the vaginal wall. If it is just isolated cystocele, you just dissect in the vesicovaginal plane, and multiple vertical stitches can be taken. You do plication of the vagina and just leave it like that.
So maybe you can make a mesh a little bit more to cover up cystocele in the tongue shape, T shape, whatever. Okay, so that is one thing. And then what is the efficacy of the tackers? What do you think is the reliability of the tacker? Not in sacrohysteropexy, we know, the problems of osteitis are there. But in case of ectopexy, some are using tackers, because they find it very difficult to suture. In such a situation, what do you think? How reliable are these tackers?
So the problem with tackers is you don't have any control on the depth. When you push, the complete depth of the tacker will completely go away. So sometimes what happens, by taking a suture, you always have a feel of the tissue. You always have a feel of the depth. So that is lacking in tackers, and we are completely surrounded by a lot of vital structures, whether it is a pectineal ligament or a sacral promontory. So in case if it gross fires or gets fired at a wrong place, you will be in trouble. And second is on the depth, when you are not sure of the structure which is lying behind the ligament, then it can create issues. So very less reported cases of tackers in pectineal ligament. But for sacral promontory, there are reported cases where chronic back pain, osteitis, everything is there. And that is why they are not encouraged across the globe for these procedures.
Yeah, yeah. So thank you so much, Dr. Sujal. I would like, it's very nice to see Dr. Atul Ganatra, sir, our
Welcome, sir.
president of IAG. Hello, sir. Good afternoon. Welcome. So it is wonderful to see you, sir.
Sorry,
So,
I thought it was the 9th. I kind of missed the dates.
okay.
No problem.
Okay, sir. Thank you so much for joining, sir. We'd like to have your blessing for this program.
Always, I think we have a very robust faculty, I think. I'm a small fry in the robust faculty. Kemche Sujal,
Sir. Very good morning.
good. And, my best wishes to everybody on the panel. And okay, please go on. Don't waste time.
Okay, thank you so much, sir. Kind enough for you to join us. Thank you so much, sir.
Okay.
So, Dr. Sujal, I would like to know, so there was a paper where I found that, tacker for pectineal ligament is better than being used for anterior longitudinal ligament, because they say the thickness of the pectineal ligament is much more than that of the anterior longitudinal ligament. That is the reason, the problem of osteitis doesn't occur when you use tacker for the pectineal ligament compared to that of the anterior longitudinal ligament. There are a couple of papers.
Please share the papers. We would like to explore that part also.
Yeah. Okay,
Sujal, tell me, sorry to intervene. Tell me now, just yesterday we did a wall prolapse in which a patient wanted a pregnancy. She had one normal delivery and she wanted a pregnancy. In a situation like this, would you still put a mesh anteriorly? Would you just...
No, sir. That is what I showed in the presentation also. We have completely switched over to posterior approach, where it is more physiological. It holds the uterus also very well. Chances of recurrence is also less, and there is no anterior mesh. So we create two broad ligament windows lateral to the uterines, so the even vascularity of the uterus is not compromised. So mesh is attached at one pectineal ligament, will go from a broad ligament window posteriorly, encircling the isthmus. It will come out again from the other window, and then it will get attached to the another pectineal ligament. So assume a patient in standing posture, it is more physiological correction. So axis of the uterus doesn't get changed. There is no anterior mesh, and you have better correction also.
What if there is a small cystocele also?
So if there is a small cystocele, then you may either do vertical stitches. You may put vertical stitches and placate the vaginal wall, or you may put a separate mesh there.
Okay.
Which is much lower down, and as the lower segment expands, it will go down and it will not come in the way of C section.
Any incidents of the uterine artery getting damaged while doing this lateral window?
Yes, you have to be very careful while doing this. If it is a unilateral damage, will not hamper. The collaterals will develop by the time pregnancy will take place. But yes, you have to be careful about the major uterine vessels.
And what is your choice of mesh?
Soft polypropylene mesh, because anything above 50 micro size will induce lot of fibrosis, and the macrophages can very well go through the mesh. So chances of mesh infection is very less. So what you need is a macroporous soft proline mesh.
But the Ethicon one is still very hard. We just used it yesterday. Bard or Medtronics are better?
They are doing little better.
Yeah.
Even the Indian meshes are now excellent.
Which one?
The Merrill company also have
Merrill is producing some very good meshes.
Good meshes. So yes. What I do also in such a thing, I like Dr. Sujal is going bilaterally, the mesh is taking the mesh around the uterus, around the isthmus. What I do is I take a vertical limb from the anterior longitudinal ligament, and at the level of the uterus, the same size of mesh I cut and make it into a Y. So I just go only on Y, and I suture that before introducing the mesh only, I suture both the limbs. So it is one V, it's like a Y. So it is a V and a long limb. So I make a window on the broad ligament. So we can see, nicely the avascular area, you make an opening. And then anteriorly, I fix one limb, and then bring that through that window, and then the other portion of the V, I fix it to the posterior one. So this is sufficient to anchor it. So we don't have to go around both the sides, and then finally fix it to the anterior longitudinal ligament. So this way you can avoid compressing the uterine artery.
But
so
then the mesh has no support in the broad ligament, isn't it?
No support at all, sir. It is just a passage for it to come through. And you can beautifully cover up with the peritoneum. Not even a small portion of the mesh will be exposed.
And
So in
what
that
about, you said you put one limb anteriorly. What if the patient has a cesarean section or has another delivery? Then what happens?
Yeah, so in such situation also, cut on the cesarean is only going to be in the lower segment. We are going to put only on the cervix, no, so it is not going to interfere with the cesarean section at all, because the incision is going to be well above. So it doesn't matter.
You
But
still
only
believe anterior longitudinal ligament is better than the pectineal ligament?
anterior longitudinal ligament in certain cases, because pectineal ligament also I've been doing, but couple of cases I had a recurrence. So now I am again trying, the anterior longitudinal ligament with this approach. I mean, with this wide limb. I found this to be a lot more stronger, and it is really holding on very well. So I am quite happy with this.
And you don't believe in doing a Moskowitz, either of you, Mala, Sulal?
Yeah,
Do you do a
Moskowitz
Moskowitz with the same sitting? Or
only
you don't?
when there is an enterocyl, no, sir. Only there is an enterocyl Moskowitz. Invariably, most of these girls, young girls, very rarely they have enterocyl, but little older women, they have enterocyl. So in such, we can combine the.
Levator can be used.
Yeah, you can obligate the pouch.
Walled prolapse. I've had about 2 patients who were obese as a result of the sacrospinous fixation, developed severe incontinence, urinary incontinence.
Yes, sir.
So that is one big problem, and almost like a continuous leak.
Constipation
avoid
and stress
Just the
urinary
benefit of
incontinence.
the delegates, yeah.
Literature says around 35% of the patients will develop SUIs with
Yes,
sacrocolpopexy, because the
Because
vaginal axis
you
is
are
taken
opening up the
mostly
anterior
there.
compartment, and posterior
Yeah, yeah.
compartment is completely. And second thing is because of the neuronal bundle that is going through, that also gets during dissection, if it is not properly taken care of,
And
that will also add to your
also
constipation.
when the nerves are getting damaged, no, the
Yes.
hypogastric nerve. So that
So
you have
that, I think
to be very
yesterday,
careful.
I must share this video. Yesterday, what we did is we could actually pick up the whole hypogastric bundle and kind of separate it, which may not be possible always, especially older women.
Yeah.
So then, do you recommend doing a TOT at the same time, or you would counsel the patient, "Okay, if it happens, we will do it"?
Sir, I would prefer to do a birth colpo suspension or a paravaginal defect simultaneously rather than going ahead with TBTO in the same
Right.
sitting. Yes.
In the same sitting?
Same
For all
sitting.
patients or for selected patients?
So for any sacral promontory, any occult history of occult SUI or episodic SUI also, you should correct it in the same sitting. But if there is no history, then patient should be counseled.
Because I've had these 2 patients which I'm referring to. These patients came to us after 2 failed attempts at a vaginal sacrospinous surgery. That makes life extremely difficult.
Yeah.
Sir, I'm very comfortable with pectineal ligament in such repeated surgery cases where even SUI does not get worsened. Patient will not have any issues of the stress urinary incontinence or constipation also.
Okay. So
Because
we just
once
had
the
a patient recently on whom tackers were used and she has developed severe osteomyelitis. I mean, that makes life difficult. I think I always suture. We don't want to.
Yeah, in fact, suturing is much easier at the promontory. So we have some quiz also, sir, after each session. So can we go ahead with the quiz?
No, sure. I'm going to just go off the line.
Yeah. Thank you so much, sir. 1 minute, so we'll go on with the quiz. Sahiti, can you display the quiz questions?
First question.
Yeah. So I'll read it out. So you have 35 seconds to answer this question. So at the end of all the sessions, we'll announce the winner. So the winner, there is a winner for each and every session, and you'll also get a prize from Shield, and we are very thankful to Shield for sponsoring this. So all of the above can be considered as a fertility sparing prolapse surgery, except hysterosacropexy, hysteropectopexy, Purandra's dynamic sling, and Fothergill surgery.
I think the answer is already.
Yeah, it's okay.
Okay.
Okay, so we have 35 seconds, yes.
Yeah, this question is only for delegates.
Yes.
Yeah.
Yeah, last 5 seconds. Timer.
Okay, so we go on to the second question. Preferred procedure for POP patient conceived after lap repair. Elective induction of vaginal delivery at 38 weeks, vacuum application at vaginal birth, forceps, and also elective cesarean section. You can choose one.
Last 5 seconds.
Yes.
Time up.
Yeah. So we go on to the last question. Considering future possibility of elective cesarean section, which method should be avoided? Hysterosacropexy with posterior sling, hysteropectopexy with high anterior sling, hysteropectopexy with posterior sling. I think all of these were discussed in Dr. Sujal Munshi's presentation.
Five more seconds. Time out.
Okay, done. Yeah. So thank you so much. So I request all of you to stay back because to know the result, it will be announced only at the end of the 4th session, and the winner definitely gets a prize. We have 4 prizes actually for all the 4 sessions. So thank you so much, Dr. Sujal Munshi. So we move on to the next session. So the next surgery is on, the next topic is going to be on fertility sparing surgery in ovarian tumors, why, when, and how. So for which we have our chairperson, Dr. Jayamala. So she is a very dynamic endoscopic surgeon and also an infertility specialist and managing director of Rainbow Hospital, Salem. So she's also the current president of Salem Obstetrics and Gynec Society. Of course, she's got various academic excellence to her credits. And over to Dr. Jayamala to introduce our speaker and take it forward.
Good evening, Dr. Malaraj ma'am. Thank you for the opportunity to win. And I would like to welcome Dr. Jayashree Natarajan. Once again, she was with us a month ago at Salem. Jayashree Natarajan has done her MS Dipendi and PD of Gynae Oncology, MCH Gynae Onco from AIMS. She is currently the Associate Professor, Department of Gynae Oncology, Cancer Institute, Adyar, ovarian cancer surgery and research. Her areas of special interest is ovarian cancer surgery and research, minimal invasive surgery, and cancer prevention in women and research interventive oncology. With that short introduction, I would like to welcome Dr. Jayashree Natarajan to give her talk on fertility sparing surgery and ovarian tumors.
Good evening, all.
Yeah, hello, good evening, Madam.
Can you see the slides?
Yeah, we can.
Yes, ma'am.
So basically, I want to discuss this topic in this way, like fertility preservation in women with ovarian cancer. In this, we'll be seeing the burden of problem and the criteria for fertility preservation and the fertility preserving surgeries, what are the options, and fertility preserving from gonotoxic drugs and counseling for fertility preservation. So as we see that there are around 6.6 million cancers across the world. In this, 1.09 affects the genital organs. In this, we have 12 to 34% of them as primary ovarian malignancies. This is the area what we're talking today. And as per Indian statistics, it will be like 1.3 women per lakh population in a year will be getting a cancer in less than 40 years who is eligible for the discussion of fertility preservation. Most of them, what we see in this age group are germ cell tumors are borderline ovarian tumors. Because borderline ovarian tumors in the spectrum of progression, they become epithelial ovarian tumors by 50 to 60 years. So in this age group, less than 40 years, which we are discussing for fertility preservation, the most common tumors are either germ cell tumors or borderline ovarian tumors. Rarely epithelial ovarian tumors. That also more commonly mucinous more than serous tumors are seen. And endometrioid and clear cell cancers are picking up more now because of increasing incidence of endometriosis. These are the cancers which are seen in the background of endometriosis. So as per the SEER data, this is data from US, we see that though the median age is 63 years, we have enough number of patients in the age less than 40 years age group. So what is the overarching question to be considered is, does the cancer patient desire intervention to preserve fertility? This one question is there all the time. Every time we feel the cancer is a big C and it threatens life. So should we offer them fertility preservation? this question comes only when we don't know whether fertility preservation will affect their oncological outcome. What is the qualitative evidence if we are providing a fertility preservation supporting current and forthcoming options in females? What is the role of the oncologist in advising patients about fertility preservation options? So how we do decide the patient whom we should discuss about fertility preservation? A lady who's aged less than 40 years and married or will be married in the future, doesn't have children, are keen to have further more children, and how much time is available. When we have a critical illness, we need to treat it. So before that, how much time is available to go for a fertility preserving options? And when we know the options, we know there are a handful of options pre-surgery. So do we have time enough to choose any of them? Decide to preserve fertility with pre-treatment counseling. The patient also should be willing. When we are offering fertility preservation, the patient also has the same question that will it affect my oncological outcome? Will I be living when you preserve my fertility? And the tumor factors, like what is the histological type, grade, stage, and what is the risk of recurrence within the period when the patient is planning for a pregnancy. And what should be the preoperative evaluation, and what the preoperative evaluation can give us clue about, and willingness to follow up an appropriate follow-up protocol. If everything is in place, we can confidently give a lady a fertility preservation if she fit into the criteria. So we know this gamut of words are not new to you. That is going for IVF, ICSI, oocyte preservation, ovarian tissue preservation. This is new to oncologists, and this is unfamiliar to oncologists. We are not practicing it, but it is more familiar to obstetricians and gynecologists who are discussing these terms every day. So basically, it is appropriate team counseling that we need an entire team. It's not only oncologists, we need a team of fertility experts and psycho-oncologists who can counsel about these issues. Many times when they speak to a psycho-oncologist, they decide that they can come for fertility preservation than when they're talking to an oncologist, because we speak more about the recurrences on the lifespans and chance of distant metastasis. And this may not happen in a single day. When a patient comes to a doctor, the first minute itself, they feel that this evening or tomorrow morning you should operate because they have a cancer. So we should allay their anxiety, and it takes multiple sessions, maybe in the same week or sometime over a week's time. We should allow them to take decision after settling with their anxiety. And the topic has to be discussed in tumor board among the oncologists, like medical, surgical, and radiation oncologists, and appropriate documentation should be there about the pre-operative fertility preserving surgery counseling. So as we all know, we have in the ovarian tumor classification, we have surface epithelial tumors, germ cell tumors, ovarian sex cord stromal tumors, and others. As we saw in the introduction itself, the germ cell tumors are the most common in this age group because their age, majority of them comes in less than 25 years of age. So 60 to 80% of cancers which we see in this age group are germ cell tumors, especially in children and adolescents and those who are not married. This is the most common tumor which we face. And after that, we have the surface epithelial tumors. In this, the borderline tumors are more common. And third comes the sex cord stromal tumors. These are usually seen in women of sixth or seventh decade, but they have a juvenile pattern also. Like granulosa cell has adult granulosa type and the juvenile granulosa type. And the juvenile granulosa cell tumor types are more common in young children. So there are other things like metastasis from other sites like stomach, breast, other are also there, but they account for around 5%. So whenever we see ovarian tumor, we should have this background that we have a spectrum of histology and they have a different management. So when we have a histopathological biopsy report, before confirming that whether we go for some other management, we should have a second opinion because we are providing fertility preservation, which is not the standard of care when it comes to oncology. The oncological principles are basically to improve the DFS, that is disease-free survival and overall survival. The oncological principles are flexed for our need of fertility preservation. So whenever we have a histopathological report, the tumor grade and histological types decides the outcome of the tumor. So we need to have a second opinion on the histopathology. If we have an expert who works on this specialty of oncopathology, then it will be better. So now coming to the borderline ovarian tumor, which we say this is the most common type, 10 to 15% of ovarian cancers, but in this age group, they are the more common ones. And these are characterized by epithelial ovarian degree of cellular proliferation and nuclear atypia. They may have some kind of stromal invasion, but they may not invade the basement membrane. So they are not malignancy, but they have other features of malignancy in the cellular level. The median age to diagnosis is 45 years. With more than 34% of patients are less than 40 years of age. We have all the histologies as borderline tumors, like serous histology, mucinous histology. We have endometrioid and clear cell tumors also. When we see serous, this is usually bilateral. But still, when we are diagnosing an younger lady, they are usually confined to the ovaries. And 1/3 of patients may have extra ovarian spread, that is, may be in the peritoneal disease also. Mucinous tumors, they are usually confined to ovaries in 80 to 90% of patients. Endometriotic clear cell tumors, majority are unilateral, majority are stage 1, but they are not good histologists to handle. So in borderline ovarian tumor, we should remember that fertility sparing surgery can be done at any stage. Invariable of stage, we can offer fertility sparing surgery because it is not malignancy. Unilateral or bilateral cystectomy or unilateral oophorectomy with cystectomy of the other side ovary, or going for only for unilateral sulfing oophorectomy with peritoneal staging. All these are options, but we should know the histology before we are offering. Say if it is serous histology, going for a cystectomy, unilateral or bilateral is okay, because the serous tumors, even if they recur as a borderline serous tumors only most of the time, and they're easy to handle. When it comes as a mucinous tumor, when we do a cystectomy, the chance of recurrence in the same ovary is very high. So when we say serous tumor, we can do a cystectomy. When we say mucinous tumor, even if it is unilateral, chance of it being bilateral is less. They are unilateral tumors. But here we offer unilateral sulfing oophorectomy because the chance of it coming back in the same ovary becomes very high. So, and what is peritoneal staging? When we say peritoneal staging, we have peritoneal, first of all, when we enter, we should have a peritoneal washings first before we do any cystectomy or any procedure on the ovaries. Then we do whatever we needed as we decide for cystectomy or unilateral sulfing oophorectomy or bilateral sulfing oophorectomy. We're sending it for frozen sections. When it confirmed like one of the borderline ovarian tumors or epithelial ovarian tumors or sex cord tumors or germ cell tumors, then we should decide on whether we need node biopsies. Node biopsies, when I say node biopsies, it is not needed from mucinous tumors and granulosa cell tumors, but other tumors need nodal dissection also. And omentectomy and thorough abdominal exploration. When I say thorough abdominal exploration, it means seeing up till the diaphragm. So if we go on with a small incision, we will not be able to see it. So if you're going with a diagnostic laparoscopy, then we can take it as an opportunity to see all quadrants of abdomen. When we're going for DLAB, we should put side pose and properly see all the areas by pushing the areas and seeing the peritoneum thoroughly. And then we decide what is the peritoneal carcinomatosis index scoring. That is how much of peritoneum is involved and how much of organs are involved in all the quadrants of the abdomen. This is called peritoneal staging. So after seeing that we have decided and we have handled the ovary, should we take biopsy from the other ovary? No. The other ovary is normal. There is no point in taking biopsy from a normal looking ovary because ovarian biopsy per se, even if you're not injuring this vascularity, it can cause fibrosis in the ovary and inflammatory changes in the ovary. It can cause infertility by doing a simple biopsy in the other ovary. So if we do a cystectomy, we know that we're done a cystectomy, and or if we done a unilateral sulfing oophorectomy or BSO or hysterectomy with BSO. If a lady is having a unilateral tumor, obviously we will offer only unilateral sulfing oophorectomy or cystectomy. But cystectomy has a chance of recurrence of about 30%. Unilateral sulfing oophorectomy has a chance of recurrence of about 11%. That is, cystectomy 1/3 will recur. Unilateral sulfing oophorectomy 1/10 will recur. If the bilateral tumors are there, if you are choosing to take out only one ovary and the other ovary we are removing cyst, obviously the other ovary which we have removed cyst will have a chance of recurrence of about 30%. So if you have mucinous tumor in one ovary only, then go on with unilateral sulfing oophorectomy. If you have bilateral serous tumors, then go with cystectomy. If there is bilateral mucinous tumor, then obviously you cannot take out both the ovaries. So take out one ovary over one side and cyst alone in the other ovary. But explain the patient that the ovary which is preserved, there is chance of ovarian tumor recurrence is there, which is around 30%. And in women whom we have peritoneal mets also, like we find that ovaries are attached to the uterus. Now you don't know what to do with it. You can't even take out the ovary alone. Then when we are landing up with hysterectomy with BSO, still the chance of recurrence is 1.7%. So nothing is free of recurrence. So when the patient says, take out everything, I'll be fine, you should explain her that even if I take out everything, the risk of recurrence is there. So better to bet for the chance when you can go for a pregnancy. So if you operate in an early stage, chance of recurrence is around 54%, but the chance of lethality is only 0.5%. The disease being too aggressive to cause death is only 0.5%. When it is advanced stage, the chance of recurrence is high, but still lethality is only 2% in borderline ovarian tumors. If you leave around 50% of women in early stage and 1/3 of women in advanced stage, they become pregnant in borderline tumors. So these points has to be addressed when we are counseling for a pre-surgical counseling. So when we say recurrences, when we say this risk of lethality, these numbers may be scary for many, saying that if I have advanced disease and if you do fertility sparing surgery, if my chance of dying is 2%, then is it because of fertility sparing surgery per se? It is not so. So just by doing fertility sparing surgery, we are not increasing the risk of lethality. The nature of the disease, tumor biology is making it come back and making it other complications and risking your life. So when we are counseling, we should say that even if we do complete surgery, the chance of recurrence is not 0. So your bargain is between 0 and 2%, even with advanced disease. So we have enough papers for whatever we are speaking, that to do conservative surgery or to do radical surgery when we have a young women who's desirous of pregnancy. We have enough meta-analysis, and you see the data from 2005. I'll keep on progressing. You see, in 2005, they have taken only early patients, and the pregnancy rate was around 40%. And as the years goes on, you see the papers published in 2020, we have enough number of advanced cases also who've been operated. And we can see on the last column that we have a pregnancy outcome around 80%, because the IVF, the way the infertility management is also improving, the way surgical oncological principles are also improving. So we can see the improved outcomes in year after year. This doesn't show that any change in the disease nature. So if we take a right decision, we can improve the outcome. And another group of patients are the borderline tumors in children and adolescents. Around 300 cases have been reported in the literature so far. And the youngest is around 3 years, and it has been in 3 to 25 years, we got around 300 cases. We find that we are offering fertility sparing surgery in this age group. Their survival is not affected, even in advanced stages. So for this age group, definitely fertility sparing surgery has to be offered. The fear will be that, oh, even in this younger age, in the childhood, the child has got a tumor, so it must be a bad tumor. It is not so. If it is borderline ovarian tumor, it respects its histology. So the recurrence patterns behaves under the histopathological pattern only. So we don't have to assume that a too younger child, it may be bad. So even in a pediatric age group, when we get a borderline ovarian tumor, fertility sparing surgeries are shown to be the gold standard. So we see that when we have operated a child, say in this literature, we saw 3 years, some are 14 years, some are 20 years, and how long to wait for a recurrence. If they recur as an invasive cancer, when it will be coming back. So what happens most of the time is that the patient comes to us and they get operated and they don't come back to us after that, saying that my disease was cured and I become pregnant even. It shows that it's a test of proof that I'm normal. So I got pregnant and I got delivered also. So we see that these women who are treated for borderline ovarian tumors or epithelial ovarian tumors in early stage, as we follow them up for multiple months, like in 74 for 75 months, the mean time to progression is 75 months in invasive recurrences. For borderline tumor to progress is around 40 to 50 months. The recurrences can come after years. So the patient should know that when we're giving fertility preserving options and when they deliver, it's not the end of the story. They have to be on follow-up. It's not only those patients who are on fertility preservation, it is the same dictum for others also who are being operated for any malignancy or borderline tumor, that they have to be on follow-up for the stipulated period. The same way, these women who are offered fertility preservation, they should be followed up for quite a long time, as we advise, for watching any recurrences. So now coming to the deadly groups like epithelial ovarian tumors. The previous one was a pseudo one, which had no invasion. In this epithelial ovarian tumors, though it is a disease of 6th or 7th decade, it is even seen in younger age group, especially those who are having a BRCA mutations. We can see them in the 4th or 5th decade even. Some are even in the 3rd or 4th decade. Getting an epithelial ovarian tumor in a reproductive age group is very less. We have only 3 to 17% of women who are with epithelial ovarian tumors in this age group. And most of them are in stage 1. That's a good news. And the factors influencing the outcome will be the stage, grade, histology, and completeness of staging. And in this age group, most of them who are diagnosed with the disease, when we say stage 1, it means that they have been incidentally detected to have this tumor, or they may have only a tumor which has grown outer size and causing pressure symptoms, not because of metastatic disease. So those who went for infertility management or those who went for some other symptoms like dyspepsia, frequency of micturition, or any constipation, then incidentally detected to have a ovarian mass, and when they were diagnosed, when they were operated, they were to be found to be in stage 1. And most of them, those who have symptoms because of epithelial ovarian tumors, are detected usually in stage 3. So outcome depends on stage, grade, and histology. So when we said when in a borderline ovarian tumor, all stages can be taken up for fertility preservation, the same doesn't hold true with the epithelial ovarian tumor. In this, the histology matters. In borderline ovarian tumors, we have serous endometrioid, mucinous, and clear cell. All 4 histologies we treat similarly, like saying that every stage, all histology we can offer fertility preservation. But when it comes to epithelial ovarian tumors, the clear cell variants and the tumors with grade 3 histology, they are horrible. They tend to recur very fast, especially within the period of 24 months. So we have enough evidence in this series to say this. So whom will we offer fertility preservation? If you ask a question, I'll say that in stage 1A disease alone, when it is epithelial ovarian tumor, not anything more than that. If it is 1C, if I am offering fertility sparing surgery, then we should send the patient for adjuvant chemotherapy also. For not for patients who are having grade 3 disease, even in stage 1A, and patients with clear cell histology, if you are stage 1A, then give adjuvant chemotherapy also. Stage 1C also, clear cell histology doesn't warrant a fertility preserving procedure. So when I say for favorable histology, overall in this favorable group of oncologists are the serous tumors, mucinous tumors, endometrioid tumors, or mixed of these, seromucinous tumors or seroendometrioid tumors or something like that. But they should be in grade 1 or 2. Grade 3 is not favorable. And same way, clear cell histology is not favorable for fertility preserving surgeries. Because the clear cell histology is notorious to develop recurrences within 2 years, and they have a high risk of extra ovarian metastasis, and when they recur, they are lethal. So they are not in the favorite group. And when it comes to fertility most common type who get fertility preserving surgeries in these epithelial ovarian tumors are the mucinous tumors, because they are the one who are usually in the fitting into the criteria. So in mucinous also we have 2 types. We have expansile type and infiltrative type. The expansile type is a good one and infiltrative type is not a good one. But we don't have adequate data now to say which one to choose. It's better to choose expansile mucinous tumors for fertility preservation because infiltrative ones have more chance of recurrence. So now the next group is germ cell tumors. We know it's also a spectrum of disease, and the germ cell tumors are the most common age group to get is in the age group of reproductive age group only. Like children and young adolescents and young adults are the one who get affected by the germ cell tumors. So most of them, more than 80% occurs in women less than 30 years. So this becomes challenging because they come with the high tumor burden and very high tumor markers, which are scaringly looking at us in the reports. But they have a good prognosis. When we offer fertility preservation, even with advanced disease, they do well, like borderline ovarian tumors. 50 to 70% of germ cell tumors are in stage 1. So this group of patients, unlike in epithelial ovarian tumors, they come early in stage 1 because they are symptomatic. These tumors have a tendency to grow very fast. So the child will have, young lady will have pain abdomen and it can go for a big size. So they'll have pressure symptoms early. So these 50 to 70% of patients in germ cell ovarian tumors, they come in stage 1, and bilaterality is rare. Bilaterality is usually seen in dysseminoma or a mixed tumor where dysseminoma element is there. So usually they are unilateral tumor. So the decision making become better when we are operating. Do we have data for this? We have data for this also. So what are the commonest times which we see? This immature teratomas. These immature teratomas, yolk sac tumors, and dysseminomas are in the number 1, 2, and 3 in the list of germ cell tumors. Immature teratomas doesn't produce any tumor markers, may not raise any alpha fetoprotein or beta HCG, it may not increase CA125. So if you get such a picture and you have a tumor in the adnexa, you should first think in this age group, it may be an immature teratoma. Immature teratoma grade 1, stage 1 is good. Stage 1 in grade 1 is good, but rest all need chemotherapy. So it is a teratoma, but it's a bad teratoma. Immature teratoma is not a good teratoma. When it comes to yolk sac tumors and dysseminomas, they raise tumor markers like AFP and beta HCG. So any women in the reproductive age group, we should ask for these tumor markers other than CA125, alpha fetoprotein, beta HCG also. And you see from the table that most of them are in stage 1. That's a good news. So we can offer them a fertility preserving surgery. And next is we have a set of chemotherapy which works wonder on them. It melts the tumors. So for women who have undergone fertility preserving surgeries, we see that they have a good rate of pregnancies, and the live birth rate is around 86.2%, and term delivery is around 83.1%, and preterm delivery is only 3.1% in these patients who have received fertility preserving options. Most of them who have undergone fertility preserving options, they receive BEP chemotherapy because this is the first line of chemotherapy. The rest all are usually not given in our Indian setup, and they may be the second line chemotherapy or third line chemotherapy when they come with recurrences. So these these drugs have a low risk for infertility, low risk for ovarian failure. The premature ovarian failure risk for women who are getting even with multiple lines is only 3%. So the interesting fact is that over 90% of survivors of germ cell tumors who are less than 40 years who received fertility sparing treatment and decide pregnancy become pregnant and give birth. So what are the interesting facts is that in the reproductive outcome, more than 90% conceive spontaneously. They don't even need a ART. Less than 5% may require ART. Live birth rate is around 86.2%. Term delivery more than 80. Prematurity is less than 5%. Rate of miscarriage is only 18.5%. When you coming to oncological outcomes of those patients who undergone fertility preserving options are 68.6% require adjuvant chemotherapy. So it's not a bad news because we have enough pregnancies even after chemotherapy. The most commonly used regime is BEP. Most menstrual cycles recover after chemotherapy within 6 months in 80% of the women. And the rate of premature ovarian failure is only 2.9%. And we said in germ cell tumor also, we can offer fertility preservation even in stage 2 and stage 3 disease. So even in stage 4, in when we choose the patients correctly, selectively chosen patients. So when we offer NACT, that is when we give the chemotherapy before surgery and wait for the response and take up the patient for surgery, even in this group of patients, we see that many of them become pregnant. So don't say no for fertility preservation in women with germ cell tumors in stage 2 or 3 or advanced disease. NACT followed by surgery is still an option for these women. So the next group of tumors, that is the third group we are discussing after epithelial and germ cell tumors, sex-cord stromal tumors. It has a spectrum of disease. In this, the most common one, which is popularly seen in the adolescent age group, is this, juvenile granular cell tumors. They are usually stage 1, less than 5% are bilateral. But we need to know one thing about this tumor is that they produce hormones. So when they produce hormones, they may change the pattern of uterine endometrium. The presentation may be amenorrhea or polymenorrhea or menorrhagia. So uterine evaluation is mandatory before we are deciding on any surgery. Not only for the fertility preserving group, for any patients with the germ cell tumors, uterine evaluation is mandatory. So since the tumors are unilateral only, unilateral salpingo-oophorectomy is an option. Here, usually we won't be able to see a healthy ovary along with the tumor. So, removing the tumor alone is mostly not possible. And it is usually unilateral tumor. So, you taking out an ovary is the right way to do it. If it's bilateral, then remove the largest tumor among the both ovaries, whichever is the biggest. Take out that ovary with the tumor. The other ovary, try to preserve the ovarian tissue by removing the tumor alone. And in this group of tumors, the granular cell tumors, we don't have to do PLND because the mode of metastasis is not lymphatic. In this granular cell tumors also, we have 113 patients in the literature who has undergone fertility preservation. The pregnancy rate is around 86.4%. And the live birth rate is around 95% among those who got pregnant. So there's another group of patients who are pregnant and then they are detected with the ovarian malignancies. The management depends upon the period of gestation and histology of tumor. To some extent, even before surgery, we can know by the tumor markers and the imaging reports, and the desire to continue pregnancy. How much the lady wants to continue the pregnancy. She already has a live issue, and this pregnancy, she may not be, totally desirous of continuing the pregnancy. Then we need not put her on risk. We can take out the mass and we can terminate the pregnancy and take out the mass. But if she's desirous of pregnancy, then we have to stretch our brain out to find out ways of protecting the pregnancy and taking out the tumor when appropriate. And these kind of patients are the ideal patients who need to be discussed in a tumor board with experts in pathology, imaging, and fertility experts. And we need to document them meticulously because this is, in Indian setup, most of the time, the decisions are taken by the doctor. That's what the patient believes. எனக்கு எது நல்லதோ அதை நீங்களே பண்ணுங்க. This responsibility becomes surrogate. But when a problem comes, you are the one who are to face the litigation. So it is better to do meticulous documentation in the language which patient understands and keep it appropriately preserved for the future problems. So next comes the route of surgery. So it's conference by IAGE. So still my vote is do a DLAP. DLAP will help you to know the nature of the tumor and size of the tumor and bilaterality, and to do a thorough peritoneal tour. Like you can go to all quadrants of the abdomen. If you need to put another side port, by putting one camera port alone and seeing is not advisable, because once you put a camera port and then we go in and see that there is mesenteric disease and we find disease behind the uterus in the POD, or we find some disease hiding behind the side of the liver. This can't be encouraged. So we have to put a side port without, we should get convinced that we're seeing the peritoneum completely and the tumor is there in the ovary alone. If it is a small size tumor, it can be removed in toto. Then we can remove it laparoscopically and put a small incision without rupturing it and take it out. That's the best way. Not to squeeze it through the port, making it spill in the bag and the port, and then the port side becomes a recurrence. If port side becomes a recurrence, it is stage 4 disease and it can't be handled the way we are handling the patient. In case you're going for an incision, which incision to choose? We said that we have to go see everything, we have to palpate everything. So we cannot do with a suprapubic transverse incision. We have to go by a midline incision. So oncologists love midline incisions. We don't behave conservative when we are, putting a knife on the skin. So we love to put big incisions. So I advise or I request do the same thing because it saves lives. Taking out the tumor in toto without any spill may help her to avoid a set of chemotherapy, which will have a set of problem, not only fertility. The chemotherapy, once taken in life, has its own lifetime consequences. So by saving the skin, we're not going to save her. So choose the right route, and if you're going by incision, then it is obviously midline vertical incision. So to summarize, an excellent table given in the November 2024 edition of Lancet On Call. You see that entire table, like they're given all histologies, borderline tumors, low-grade serous, low-grade endometrioid, mucinous with expansile, clear cell carcinomas, high-grade serous, high-grade endometrium and everything. And mucinous carcinoma with infiltrative invasion. What in this, you see the green ones are the favorable oncological selection. These green ones, without thinking twice, you can take them for surgery for fertility preservations. Red ones, a big no, because they don't have a favorable prognosis. Yellow ones are those you need to use your selection criteria. You need to go for a proper board discussion and discussion with the patient before if you're choosing them for a fertility preserving option. So we see that in stage 1A, in the entire spectrum, you have a green line. So it shows that in stage 1A, we have no doubt. In stage 1B, in borderline ovarian tumor, we have no doubt. Rather, in the borderline ovarian tumor, in any stage, we have no doubt. So stage 1A, no doubt. Borderline ovarian tumor, no doubt. In stage 1C1, who and all we can take? If it is low-grade serous carcinoma, low-grade endometrioid carcinoma, mucinous carcinoma with expansile invasion. That is a good type of mucinous carcinoma. Or the clear cell carcinoma 1C1, but this group will take an adjuvant chemo also. So 1C2 is possible with mucinous carcinoma with expansile invasion alone and in borderline tumors. Rest all a big no for fertility preservation. Coming to the other histologies, germ cell tumors, the small cell carcinomas, granular cell tumors, certainly lady cell tumors, and certainly lady cell tumors with other varieties. So we see germ cell tumors like borderline ovarian tumors, S in all stages, and granular cell tumor and certainly lady cell tumors, S in stage 1A, and granular cell tumor, S in stage 1C1 also. The rest all are red lines for all practical purpose. And these yellow ones we can discuss. And these symbols say that for this, say, stage 4, germ cell tumor and certain lady cell tumors in 1C2 and 1C3, we don't have enough evidence. So they have given it as some given as green line and some as red lines. So now with these two tables, this is what I want to tell this day today, that borderline tumors, good S, and 1A tumors, yes, 1C1 and 1C2, the good histologies. Germ cell tumors, yes. Granulosa cell tumor, 1AS, and certainly cell tumor, 1AS, and granulosa in addition as a perk of fertility preservation in 1C1. So next is chemotherapy risk, because chemotherapy has a gonotoxic effect. The chemotherapy given in gynecology, can take it in broad lines. Most of them are paclitaxel and carboplatin as a first line, which is unknown risk. That's what is given here. And the second one, for germ cell tumors, we have BEP or EP. Okay. So this BEP or EP, they have not given anything, that no significant decrease in AMH. They come in the low risk group. So when we are discussing the surgery options, we need to discuss that these drugs are acceptable when we want to preserve fertility. So when we have a patient who are going to take gonotoxic drug, if we have time, we can go for the normal ovarian stimulation and take oocyte and preserve it, or we can go for a ovarian tissue cryopreservation, or no, then we can go for the treatment straight away. So next comes the follow-up. Is it follow-up is mandatory? So we know that they can recur later also, even with borderline ovarian tumors with invasive cancer. So the follow-up pattern for most of the oncological tumors are same. That is, you call them every 3 monthly for first 2 years and every 6 monthly from 3rd year to 5th year and annually after that. For germ cell tumors, when we have stage 2 to 4, we call them more frequently. Say for the first 2 years, we call them even 2 monthly to know whether they have any recurrence. Because if we provide them NSCT and fertility preserving surgery for a stage 2 to stage 4 germ cell tumor, there's a kind of apprehension that they may come back soon. So for that group alone, you can even call them more frequently. Most important thing in the entire talk is this part, is oncofertility counseling. So when we shouldn't be overwhelmed and overexcited giving oncofertility options to them and without knowing what is there. So we should know this age of the patient, our smoking history, presence of partner, medical history, ovarian reserve, AMH and ovarian antral follicle count before surgery, and any previous treatment for infertility, previous treatment which can have a potential impact on fertility, contraindication to medical or surgical fertility preserving options, is there any hereditary conditions, and what is the treatment we are offering? Do they need chemotherapy, the regimen to choose? RT is not an option in ovary. So any endocrine therapy, surgery, what is the duration of treatment? How long the patient should stay without going for further fertility management after treatment? All these needs to be discussed preoperatively. Some patients will get operated when they are cured, even the next month they come back and say, I want to become pregnant, because you say the disease may come back anytime. But that's not the ideal way. We ask them to wait at least for 6 months for the organs to heal and to know whether any immediate recurrences are there or not. So the patient should know that treatment 6 months and follow-up 6 months is mandatory before going for any oncofertility treatment further. Because if the patient is operated and she receives chemo also, usually it takes at least 6 months for the treatment to be completed, primary treatment itself to be completed. So pre-treatment ovarian reserve, we have antral follicle count and anti-Mullerian hormones. These are the recommended ones. But the patient should know that having a good antral follicle count or AMH pre-surgery doesn't guarantee her pregnancy post-surgery. Most of the time when we do surgery, the other tube may get blocked, or other tube may go for some kind of suppression. The patient should not have this opinion that I have a good chance of fertility because my pre-fertility AFC and AMH are good, so I am the right candidate for infertility treatment after that. So the AFC and AMH has to be repeated before she is going for treatment post-surgery, and patient should understand this. Whatever we are taking is like a baseline to know whether to offer fertility preservation or not. If AFC is less, AMH is less than 0.5 and AFC less than 5, the candidate itself is not a good candidate for fertility preservation. It is not to know what will be our outcome after treatment. So we have a number of interventions, which I don't have to be explaining that all these options are there. So before saying no, we should know all the options in the oncological side and the fertility side. Oncological side, if we decide, usually we send them for a counseling with the fertility expert for the other options in the fertility chart. So the checklist is very important. First thing, from oncological side, referral for a fertility consultation. If you're the primary person, if you're not handling fertility, then you should refer for a fertility consult. And we should give right information about impact of disease, treatment on fertility, option of fertility preservation. Then comes patient assessment, general health, risk of fertility preservation, age, ovarian reserve, nature of predicted treatment, information provision for fertility preserving options, cryopreservation issues, fertility treatments, future pregnancies, other parenting options, because not necessarily the child, the lady or child should opt only for their own kid. So all the options, the entire spectrum has to be offered to them. We should give them decision aids and time. Decision aids may be in the form of pamphlets or videos, and other main thing is time. So when it comes to intervention, we may choose with all the previous things like no fertility preserving interventions. We may just need a GnRH and an agonist or oocyte preservations, or we can go for a cryopreservation in embryo or ovarian tissue cryopreservation. So coming to the fertility discussions, the timing of pregnancy and her fitness of pregnancy post-procedure may not be the same for the pre-procedure. These things has to be discussed when we are taking this in the pre-pregnancy counseling. And you see here, it is given in bold capital letters, the documentation of stored material of all these, that whatever we are given, that awareness materials and what and all were discussed in which language, we should have a standard forms for the patient to understand and fill and give. The informed consent forms, all these needs to be stored. To summarize, fertility without compromising curability should be the goal. Fertility specific surgery options depends on stage, histology, and grade. So we need to be sure of what we are handling. Patients should be aware of the available options and understand the outcomes, both in sites of oncology and in fertility. So there's a timeline in patient undergoing fertility sparing surgery. We spoke more about the pre-surgery things. There is something about pre-chemo also, like ovarian function assessment, ovum or ovary preservation. During chemo, there is a role of GnRH agonist with add-back therapy to keep the ovarian reserve, and post-chemo surveillance of ovarian function, a baseline AMH 6 months post-chemo, and pregnancy plan, the timing, what is the role of ART if required for pregnancy, and some patients may not be in the age group even to think about pregnancy post-treatment. They may be far from pregnancy. Say they are career ambitious and they want to finish a set of duties before going for a relationship or pregnancy. Then oocyte cryopreservation even after surgery is an option. These things has to be considered. So it's not a one-point discussion. It is pre-surgery, pre-chemo, during chemo, post-chemo, and post-treatment. In every line in the timeline, we need to discuss about these issues. So it's not an individual decision. Like oncologist or a gynecologist who's operating on this patient will not alone think about and decide what to be offered. It is always a teamwork. If we put all things in place, then it will come to a shape. Thank you.
Thank you, ma'am. Thank you for an excellent, elaborate, and clear-cut take-home points. A few questions. Like you said, mucinous is the borderline ovarian tumor. The recurrence is more than your serous. And is there any risk of malignancy when it recurs?
So I'm not saying that mucinous chance of recurrence is more than serous. Serous can also recur. What I'm saying is when we do a cystectomy, chance of the serous tumor coming back in the cyst is less. If we do a cystectomy for a mucinous tumor, definitely will come back in the ovary.
Okay.
So on the serous tumor, we choose cystectomy because usually they're bilateral. So we have no option of taking out both the ovaries. So we try to do more conservative, thinking that whatever ovary is left out may help in fertility preservation. But mucinous tumor gives a choice for us. It is usually unilateral. So we can take out one ovary and keep the other ovary preserved, because going in again and again will have a problem. And one more thing which I want to discuss and I forgot to discuss is when we are following up these patients, since these patients are in younger age group and they have a huge demand for hormones from the ovaries, and when we take out an ovary, the other ovary has to compensate for the work, and most of the time they come back with some cyst of 4 to 5 centimeters, which is more intriguing how to handle it. So we shouldn't be overzealously thinking that this time it has to be a recurrence. So we can keep them on follow-up if the tumor markers are normal and other parameters are normal, and handle it only we know that it is something to be handled. So taking out others, many times it happens that we go in and take out the ovary and send it, they say it's only a hemorrhagic cyst or follicular cyst, because other ovary has to work more now, one partner is gone. So we need to keep it in mind that we don't, oncology is bad, but oncology is not very bad. So we need to balance the risk and keep the other ovarian cyst in observation for some time if it looks subtle.
So this mucinous tumor, madam, does it mean that you have to definitely do a oophorectomy only, or just to avoid recurrence, or can we take a chance?
That's the best course. If mucinous tumors are there in the ovary, the best course will be to take out. Otherwise, what will happen? You will have a recurrence again in the same ovary. You'll go on again and again operating that ovary. And usually mucinous tumors are unilateral. So the option of going for a saving other ovary is there. So we can take out the ovary. If you take out the mucinous tumor, the chance of recurrence is very high.
Suppose if you are going to do only a cystectomy in such a situation, and immediately after that do an oocyte cryopreservation for her, and then if it recurs, then we can go for an oophorectomy.
What I'm saying is, if you are doing a surgery, an intra-op, you have a normal CA 125, you have a cyst, and with the cyst appearance, you feel it is mucinous, then go for a unilateral salping oophorectomy. If you've done a cystectomy, and then now you are left with no option. So I won't say that if you've done a cystectomy, now immediately go in and take out the ovary. Because if the recurrence comes, then again you can go inside.
Yeah, that's what. Yeah. So,
I mean, the decision making before taking out our probes is important. So once we've taken out the probes and we are closed, then going again is like going for a second surgery only. In that case, we can wait and watch for whatever we have done.
Yeah. So because moreover the consent also we wouldn't have got. Suppose if it was a mucinous and we cannot just like that on the table do an oophorectomy. We have to just.
And this thing, I think I failed to mention it. Like if you're going in for a ovarian surgery, you should take consent for complete surgical staging. We cannot go in for a consent only for a cystectomy, or we cannot go in for a consent for USO, because we don't know what will turn up inside. So if you're going in for a surgery in young women, we can explain them. If you have a tumor, then this, I mean, I cannot take out the tumor now. Without taking out the tumor, I want to know what is it. The chance of it being a malignancy in your age group is say less than 1%. But I need to know what I should do now immediately. Should I go for a complete surgical staging, or do you want to confirm the histology and you want me to go again and do a second surgery? So if the patient says, no, I don't want to go for any big surgeries, I just want to have that ovary alone removed, it's her own risk of going for a second surgery. But if you don't explain this and we take consent only for a cystectomy or say unilateral salping oophorectomy, and we go in and we find a tumor, say only nomentum, or we find that this tumor is a grade 3 epithelial ovarian tumor, which needs nodal dissection, omentectomy, and peritoneal biopsies. Then, if you don't have consent for it, then it is legally not okay.
Okay.
It's
So
very
Though
difficult
it is
to
very
count.
scary to say that if I go in, I can find a cancer also. But we need to explain that the chance is very, the frill is very less. Like you will have very less chance of having a malignancy. But in that case, what do you want me to decide? This point to be discussed before going for a surgery. Because the surgery in unmarried women itself is a big anxious thing. So I don't think I'm adding this one more word, like, the chance of it being a malignancy. In that case, what do you want me to do? We're not offering her saying that I will definitely do this. We're going to offer them saying that, do you want me to wait and discuss with you further and then go for further surgeries if required? Or will you allow me to go on with the surgery? Like
no.
every time we take a surgery consent for a ovary patient, we take consent for stoma. It's not that every patient gets a stoma. The chance of stoma is very less. But if I don't get a stoma consent, I won't operate.
Yeah, right. So suppose you're operating on a chocolate cyst, but the biopsy is turning out to be and chocolate cyst. Along with that, you are also having an endometrioid tumor component. So, so in such a situation, what would you do? You have to.
I would do surgical staging. I won't remove the other ovary and uterus, but I will do surgical staging because we need to stage the disease.
Other things are all
we say 1A disease, endometrioid, and then later, and we're going to let the patient off also. Like we're going either to give chemotherapy or without chemotherapy, we're going to let the patient off. And if we do only remove the ovarian cyst alone or ovary alone, and discussing a tumor becomes too difficult for the medical oncologist or gynae oncologist to decide to give chemotherapy or not. Okay. So, and giving this becomes unstaged. We can't call it a stage 1A unless we do a staging. So if we have a malignancy, especially this endometrioid, clear cell, I said there is no way we can preserve fertility in clear cell tumors because they're notorious. So if endometriosis is clear cell, we are not in a point of discussion of fertility preservation alone. Endometriosis with endometrioid tumor, we have taken out a hemorrhagic cyst and it comes out an endometrioid tumor, then we have to discuss about going for a staging procedure.
Thank you. Very,
What
very
happens
excellent.
after they finish the family? What is the follow-up like? You have done a fertility sparing and then they had babies. And then what is the follow-up after that?
That's why the follow-up will be regular as per the oncological principles, nothing to do with her family completion. Most of the time they get, they get settled. Like I had done a surgery, I got a child and my shows that I'm okay. I don't want to come back. They should understand that this is a process. The tumor, if it's a borderline also, it has a tendency to recur even across a decade or so. as an invasive cancer, or it can recur as a borderline cancer, or other tumors which are epithelial, we have treated them, or germ cell tumors, they have tendency to come back. So we need to tell them like we have to be strictly on follow-up, because when we offered a fertility preserving option to them, you still left the other organs which can have a chance of recurrence inside. So they can be on follow-up. Should we do a completion surgery? If it is a borderline ovarian tumor, if I've done one side, I have done a unilateral salpingo-oophorectomy, and other side also had a tumor. I've done only cystectomy. I know it's going to come back. So if the family is completed, I'll prefer getting the surgery done, because when it's coming back, it is not going to be in the ovary alone. It can be in the peritoneum or distant mets also. So the point of discussion is like they should definitely be on follow-up, and the time for completion surgery should be discussed when they're coming up for the follow-up.
So
Thank
thank
Not necessarily at a fixed age, like say 35 years or 30 years. The time for completion surgery can be discussed, but follow-up is definitely a must.
Yeah. Excellent, madam. Very, very nice, clear, crystal clear presentation and discussions. Very nice. So I think we will, for want of time, we will stop with this. Though I think it is a never-ending discussion we can have with Dr. Jayashree. That is the amount of knowledge she has on this particular topic. Very, very renowned person when it comes to gynec oncology. Thank you so much for your time and your presence, ma'am. So we have some very important, quiz questions just for our delegates. So Sahiti, can you present them? Yeah.
Yeah. First question, ma'am.
Yeah. So bilateral tumors are more common with number one, borderline endometrioid tumor, mature teratoma, borderline clear cell tumor, dysgerminoma. You have 35 seconds. For the benefit of those who joined in late, so this is a poll. So you can choose the right answer in 35 seconds, and the results will be declared at the end of the next session. And you have a prize for each session.
Last 5 seconds. Timer.
Yeah. So the next question. Follow-up with tumor markers is not useful for detecting recurrence of yolk sac tumor, dysgerminoma, immature teratoma, all of the above. So your time starts now.
Last 5 seconds. Timer.
The last question. Fertility preserving options are not possible for borderline serous ovarian tumor stage 3, borderline mucinous ovarian tumor stage 3 germ cell tumor, and high-grade serous carcinoma stage 2.
Five more seconds. Timer.
Yeah. So thank you so much, Sahiti. So we move on to the last and the final session. So for which I would like to welcome Dr. Priya Lakshmanan to introduce our speaker, Dr. Devan Jogal. So Dr. Priya Lakshmanan is can I have Dr. Priya's CV, please? Yeah. Dr. Meenakshi is not able to join. So Dr. Priya Lakshman is a very renowned endoscopic surgeon from Chennai. She is the director of IAGE Hospital, and also she has advanced endoscopic training in Strasbourg, and also she has an FOXY accredited endoscopic training center, and organizing chairperson of EndoLive, and also executive committee member of IAGE Tamil Nadu chapter. So over to Dr. Priya to introduce Dr. Devan Jogal.
Yeah, thank you. On the outset, I would like to thank the team IAGE and Dr. Mala for the wonderful opportunity given. So I would like to invite my next speaker, Dr. Devan Jogal. He's a director of Jogal Women Hospital and head of minimally invasive surgery, Department OBG of Adani Medical College. He's an executive committee member of National IAGE chapter and executive committee member of Gujarat chapter. And he has trained more than 100 gynecologists in endoscopy. So over to you, Dr. Devan Jogal, to present on fertility sparing endoscopic surgery, why, when, and how.
Thank you, madam. Thank you for kind introduction. And I would like to thank Dr. Mala, madam, and team IAG for giving me such a nice opportunity. Today's my presentation is on fertility sparing endometriosis surgery. Though I think one lecture is not enough for endometriosis, but then I'll try my best to explain most important things which we need to discuss. And I'll try my best to enlighten all the aspect of fertility sparing endometriosis surgery. So at the outset, for introduction, endometriosis is a chronic inflammatory condition involving endometrial gland. It affects 10% of women of childbearing age group globally and 40% in adolescent. They have abnormalities up to 50% in women with infertility, and 70% of women who are suffering from chronic pelvic pain has endometriosis. It has been suggested that superficial ovarian and deep endometriosis, if we divide, we can divide it. Lesions are differently, manifestation is different, but then if you see to it, there are 50-60% chances of superficial, 44% chances of ovarian, and DIE, which is deep infiltrating endometriosis, 5% respectively chances are there. Mechanism, though initially it was thought that cyclical retrograde menstruation is the cause for endometriosis, but then ultimately now we have evidence that even in brain they found endometriotic gland and endometriosis. So now that theory we have to relook, and definitely it is estrogen production which is mainly affects this kind of situation. Sites, the lesion may involve all the organs like uterus, ovaries, vagina, fallopian tubes, intestine, urinary tract, or even diaphragm and peritoneum. We see daily that are affected by endometriosis. So clinical symptoms include dysmenorrhea, which is probably one of the most important factor or most important clinical symptom. Then dyspareunia, subfertility, abdominal pain, heavy menstrual cycle, postcoital bleeding. Most women with endometriosis suffers physical and emotional pain and that kind of condition day-to-day in day-to-day activity. And these symptoms, usually in all these symptoms, pain is very significant, which we have to address. Classification, usually there is a revised American Society for Reproductive Medicine, ASRM, RASM classification, but then it has got a little bit of problems where DIE, which is deep infiltrating endometriosis, is not very much considered in that classification. So we usually use Enzian classification, which is which involves deep infiltrating endometriosis also. There are, if we go into detail of Enzian classification, there is Enzian U, which is ultrasound, Enzian M, which is MRI, and Enzian S, which is surgical. So you do ultrasound or MRI or surgically, if you see, you can classify in that Enzian classification, which is very good in my opinion if you practice it, and it is universal language which we can say, in which we can speak. Now we'll start with endometrioma, which is chocolate cyst. So endometrioma, usually chocolate cyst, whenever you get it, it is not necessary to operate. But then endometrioma, it is one of the part of endometriosis where you have to go for fertility sparing surgery. You may get C125 little bit raised in chocolate cyst. Almost always in endometriosis and in chocolate cyst or endometrioma, you get C125 little bit raised, but that is the benign process and benign thing which you have to keep in mind. Now, conservative surgery includes cystectomy. If you go for conservative surgery, cystectomy is the only option. Better you do it in follicular phase, and recurrence rate is as far as or as much as 40 to 50% in 5 years. So ultimate goal of surgery is restoration of anatomy, removal of the all endometriotic lesion, and prevention of adhesion. For bleeding, minimally use cautery instead of cautery. If you are comfortable, it is always better to go for suturing. Standard steps in fertility enhancing or fertility sparing endometriosis surgery, though there are so many different steps, but then if you are going for standard steps of fertility sparing surgery, first there has to be a delischolysis, second is sigmoid colon mobilization, third is ureterolysis, which is with endometriotic approach we are going. Then if ovaries are involved, then ovarian cystectomy has to be done. After doing ovarian cystectomy, you have to lift both the ovaries and stitch it, or you make it apart with the lateral pelvic wall so that access to the rectum is possible. Then there will be pararectal space dissection, and then if rectum is involved, then rectal shaving or bowel resection and anastomosis or whatever it requires, and then clearance of endometriosis surgery. So laparoscopic excision of endometriosis has marked benefit over laparotomy with respect to analgesic requirement, recovery. Simple drainage of endometrioma is associated with high recurrence rate, and there are so many cases where after doing ovum pickup, when ultimately small amount of chocolate cyst is there, what they do is they rupture it with the IVF pickup needle. But then we are getting so many patients of abscess after that. So in my opinion, personally, I would not recommend to go for only rupture or only drainage of endometrioma. That is my personal opinion. Excision of the cyst compared with drainage of and coagulation of cyst wall is associated with low recurrence rate. Pain symptoms will be less if you go for cystectomy, and higher pregnancy rate definitely, because pain will decrease and the abnormal environment of the ovary will be removed. Then there is a chocolate cyst, which surgery for the chocolate cyst, which we need to see. This is one of the surgery for chocolate cyst. You can see here, cyst is on the left side. Okay, and left-sided chocolate cyst, we want to take out chocolate material, just rupture of that cyst. Thereafter, if you can see, we are doing suction. This is the suction, what we are doing to take out all the chocolate material. If you take out all the chocolate material out, then there is a cyst. You can see here. Yes, cyst wall. Now, if you can see here, cyst wall, what you can do is cyst wall removal should be very gentle. If you can see here, there is little bit of oozing or bleeding. Second important thing is you have to keep on changing your instrument. So position of your instrument should be changed frequently. Do not try to take it out or peel it off in one go. You can use energy source. Judicious use of energy source is not much of harmful. At the level of base where chances of bleeding are more, from there you can use energy source just to get less bleeding. Use of bipolar, usually I don't recommend, because then with bipolar energy is more, and chances of burning or chances of damaging the good amount of follicles are more with bipolar. So if at all you have bleeding in such kind of areas, it is always better to go for suturing. So it is again debate. If you say that in each and every case you should go for suturing, I would say no, not in each and every case. When you get bleeding and when you don't want to go for cauterization, like you don't want to use a bipolar or so, which is not recommended also, then it is the suturing which is the better option. One more thing, what you can do is you can, fold both the ovarian edges, and you can hold it with your ball grasper and keep it closed for some time, just to decrease bleeding. This is again suturing, which is been shown, and this is a Vicryl which we are using. Again, it is only when you have bleeding and you don't want to use energy source, it is always better if you use suturing. After suturing, if you go and again after 2 to 3 months, you go for ultrasonography of these patients, usually you will not find any problem. Usually after such kind of suturing, it is, ovary is healthy and you cannot even identify that cystectomy or chocolate cystectomy was done from that side. So suturing, how to do it? It is approximating stitch. Please remember, suturing should not be done in a very tight manner or tight fashion, because then ultimately again you are going to damage it. As far as possible, if bleeding is not there, then suturing is not required. So, and as I already said, approximation is the only aim in such kind of patients. So effect on AMH. AMH is anti-Mullerian hormone, which represents ovarian reserve. Endometrioma alone decreases the AMH by the factor greater than 3 compared to normal ovarian decline. Surgery for ovarian endometriomas may result in reduced ovarian reserve. So for fertility point of view, there are different things which we need to consider, because doesn't matter how good you are or how good surgery you will be doing, but still AMH is going to go down. So if this patient is for fertility or for IVF, you can go for ovarian stimulation. You can go for, embryo freezing after taking out ovaries, and then you can go for surgery and then embryo transfer. This is one of the way with which you can work. When patient has one or more ovarian endometriomas, the main objective is, to maintain ovarian reserve and to give her best result after surgery. So if, as I've already mentioned, if it is for IVF, then you have to consider risk versus benefit. So either you go for surgery first or for IVF first and then for surgery. Counseling should be done. Patient many a times what happens, pre-operatively patient's AMH is something different. Post-operatively patient comes, our AMH is different. Then many a times patient comes with complaint that AMH has gone down. So pre-operatively you should go for AMH. Pre-operatively you should counsel them that AMH is going to go down only. What usually I do is I explain them, if at all surgery is necessary, what I do is I explain them that it is the same like you have bucket of apple, where the 10 apples are there, where 5 apples are of good quality and 5 are from bad quality. So if you count all together, there are total 10 apple, but if you count which are eatable, which you can eat, there are only 5. So same thing here. If you count entire AMH will be more, but then if you remove all this endometriotic or chocolate cyst or chocolate affected follicles, then AMH becomes less. So we will take out this part, and then AMH will be less. Now we'll move on to adenomyosis, because if we talk about fertility sparing surgeries, endometriosis, in adenomyosis and chocolate cyst, these are the most common things. Two are the most common things. Adenomyosis is endometrial gland and stroma within the myometrium. Adenomyosis may impact reproductive outcome, reducing the likelihood of implantation and increasing risk of miscarriage. Meta-analysis showed that DIE and adenomyosis decreases the chances of pregnancy by as far as much as 68%. A recent systematic review found that fertility sparing surgical treatment, adenomyosis surgery, that results in high success rate in control of pain and menorrhagia, pain, menorrhagia, and other symptoms. Furthermore, conservative surgical management facilitates conception, and that is proven beyond doubt. Yeah. So this is one more case. This is adenomyosis. You can see this is particular posterior wall adenomyoma. In adenomyosis surgery, what usually I perform or what I usually do is I usually always use vasopressin. You can see here. There are a few different techniques of doing adenomyosis surgery. There is a triple flap technique, different few more techniques. What I usually use is scooping technique. What or wedge resection, what we say, why it is good, because approximation is easier in such kind of surgery. Then what you have to do is, if we are talking about fertility sparing surgeries. So it is always better you do ultrasound on your own and you see that from endometrium, what is the distance of that adenomyoma from the endometrium, so that you will be having idea that how much area or how much centimeter you should go and cut in the vertical midline. After cutting vertical midline, you can see here my assistant is giving traction. He is holding from the opposite side. And what I'm doing is known as wedge dissection, or which is known as scooping technique, what I'm doing right now. Always remember that peritoneum, which is upper peritoneum, which is serosal layer, I mean to say of uterus, that has to be kept intact for the suturing. So many a times it happens that people, they do adenomyomectomy as they are doing fibroid surgery, myomectomy, and then ultimately they don't have both edges to get approximated. Okay, so then there is issue. So then there is no approximation. There is no good approximation because tensile strength of this adenomyotic or endometriotic tissue is not very good. So what happens that you cannot approximate them if you don't have serosal layer remaining, which can be approximated. So this is how we can take that out. After that, suturing. So suturing, always it is better to go for the baseball pattern of suturing, which gives more strength to your suture line, specifically in such kind of patients where fertility is the concern, because she is going to get pregnant. And if you give a good scar and good suture line, then it will be definitely going to be useful for her. So this is a pattern of baseball pattern of suturing with barb sutures, which we are using. Vertical midline scar was given because in that I'm more comfortable suturing. This is the last part of suturing you can see. And as I said that it gives a good strength. This is the last view after doing adenomyomectomy. So this is how we can do it. Now, deep infiltrating endometriosis. So DIE, or deep infiltrating endometriosis surgery, it is, let's say, infiltration of the endometrial gland and stroma into the peritoneum more than 5 millimeter. Usually that's what we say. DIE is most often associated with rectovaginal and rectal involvement, but then it may involve ureters, intestine, uterine supportive ligaments, pelvic side wall, bladder, vagina, and other extrapelvic organs. DIE has a prevalence of 0.2% to 0.5% of population in women, and it has prevalence in estimated approximately 3 to 10%. Surgery is usually indicated in patients with DIE, and fertility sparing endometriosis surgeries generally shows improvement in pregnancy rate because the inflammation will decrease, patient will have less pain, patient will have less dyspareunia. So definitely improvement or fertility is going to get improved. Surgery is indicated when it is indicated, pregnancy outcome is good. The surgical management of DIE ranges from the bowel shaving, bowel resection, and it goes on like reimplantation or bladder or bowel involvement if it is there. Now, whenever it is possible, conservative bowel surgery should be attempted whenever it is possible. There are different criteria for conservative bowel surgeries. As far as possible, personally, I prefer shaving. So I very less in cases I go for resection and anastomosis when it is highly required. Otherwise, my first choice is always shaving. And if I can go away with only shaving, then it is always better. Second choice would be discoid. Discoid is again another option, and chances of leak after discoid is very less. So it is definitely a better option. When you don't have any other option, then you have to go for resection and anastomosis. So I have not shown videos of bladder or bowel surgeries here, but those are interested, they can go to my YouTube channel, and there are videos available over there. So, conclusion, endometriosis and infertility are two related diagnoses that impair a woman's daily life and functioning reproductive goals, which can cause a great physical and emotional instability and psychological distress. Unfortunately, expected management and medical management have either limitation or effect is less. So whenever it is required, surgical line of treatment is the best line of treatment. Definitely, I'm not against medical line of management, and it is in in many cases it is useful also. But then in endometriosis, sooner or later surgery is almost required. Surgery has added benefit of avoiding progression of symptoms like occlusive bowel syndromes, ureter, avoiding endometrioma rupture, abscess, confirming benign pathology in case of suspicious case of endometriomas. Awareness is very much necessary, and multidisciplinary approach, correct management, it is very much necessary. So thank you everyone for giving me such a nice opportunity. One more thing which I would like to emphasize is MRI. So in endometriosis cases, whenever we say that MRI is best option, there is no question about it. But many of our gynecologist friend, when they advise MRI to that patient, they just write MRI pelvis or MRI abdomen and pelvis to endometriosis patient, and they go and they get MRI done. So please remember, those who are practicing endometriosis or those who are regularly doing endometriosis surgery, it is wastage of patient's money. When you only go ask patient to go for MRI, patient goes for MRI and comes back. So please remember, whenever you want to advise patient to go for MRI, you have to ask that patient that, see, if you want to go for MRI, you have to be on liquid diet at least for 10 to 15 hours before getting MRI done. Second thing is, at the night you will give her 2 tablets of Dulcolex, so that at the time of MRI rectum should be empty. In the morning you will give her enema, so that again rectum will be empty. Before going for MRI, MRI person will do ultrasonography to see that rectum is empty and bladder is partially filled. So bladder has to be partially filled. It should not be completely full, or it should not be completely empty. Then approximately 150 to 200 ml of normal ultrasound jelly should be put inside the vagina as well as inside the rectum. Okay. If there is more peristalsis which is seen, that will be disturbing factor. So they will give injection Buscopan to that patient. And after this much of preparation, MRI should be done in endometriosis patient. And believe me, that MRI film, when it will come to you, even you will be able, being a gynecologist and not radiologist, to identify that whether she has any bowel nodule, whether she has any bladder nodule, or she has any problem in the vaginal nodule, or in terms of so and so on. So please remember, if you write only MRI abdo-pelvis, it is wastage of money, your time, patient's money. Okay, so if you want to diagnose something on for endometriosis, this is the protocol with which you can send those patients. My patient, when they come to me, they know that MRI is, I'm not going to do MRI urgently today. Even if those are patients are referred from somewhere else or some different state, even they come, they know that MRI will take at least 2 days. Because then that MRI we will sit with our radiologist friend and see, and then we comment. So this point I wanted to emphasize. Thank you, everyone. If you have any questions.
Thank you so much, Dr. Devan Jogal. Very well taken, and excellent tips, and very, very valuable points. We'd like to hear more from you. Before that, let's go to the pool, because it takes some time for them to finalize the results. So after that, we'll have the discussion with you. Priya, you also hold back. Please go hold on, Dr. Devan Jogal also. So Sahiti, can we have the quiz, please? Yeah. Okay, the first one is, the effect of endometrioma on AMH level is increases, decreases, no effect, none of the above. 35 seconds, and here the time starts now.
Five more seconds. Time up.
Okay, thank you. The second question, please. Possible mechanism of infertility in endometriosis is altered tubal motility, altered tubo-ovarian anatomy, impact oocyte pickup, all of the above.
Five more seconds. Timer.
Yeah. Last one, please. Size of the ovarian endometrioma beyond which cystectomy is indicated: 3 centimeter, 8 centimeter, 10 centimeter, 6 centimeter.
Five more seconds. Timer.
Yeah, thank you so much. As we are finalizing the results, it will take another 5 minutes. So we'll have the discussion with Dr. Devan Jogal. Yeah, now go ahead, Dr. Priya.
Yeah. Dr. Devan, that was a wonderful presentation. So my first question is, what is your take on using vasopressin for doing an ovarian cystectomy, that is endometrioma resection?
There are so many good surgeons who are using it frequently and they find it very useful. Though I agree with them that temporary decrease in blood flow will help us, because then our field will be less bloody and we will require less use of energy source. So I'll say yes, but then personally, if you ask, I don't have much of experience doing it. I'm not regularly doing it. But then if someone uses it,
The thing is, it is very effective in controlling the bleeding part, but you wouldn't be very sure that you're entering into the right plane and injecting the vasopressin. So the layers are not perfect. Like you can even enter into the ovarian parenchyma and give the vasopressin and start dissecting in the wrong plane of cleavage. So that is one thing.
That's an issue. I'm always worried about, since I'm not using it, I'm always worried about the negative effect of vasopressin when you are injecting inside the ovary, because the arterial supply is directly from the abdominal aorta. So this is somewhere where I have a little bit of fear. So that's why I'm not using
Have
it.
any experience on lasers, plasmas, sclerotherapies for
No, ma'am. And personally, I think those are good things, but then it is upcoming. So when there is no sufficient data available about safety of these equipments or instruments, I am not recommending, and personally, I'm not using it.
Okay, fine. Your take on endometriosis fertility index scoring?
Ma'am, I think
Because we operate and infertility specialist handles the case. So it will be better if we report on endometriosis fertility index, right?
100%. And as I said, there are so many classifications available, but then most promising one is NGN. So I'm very surprised to see, when last time I went to Nairobi just maybe 20 days back, they are using NGN like anything. So it's in India we are not still using NGN like in that way, but then NGN is a common language which we speak, and then DIE is better reported in NGN only. I did not find any other classification which is suits that. And see, as you have rightly mentioned, that maybe surgery is done at Bangalore, let's say Hyderabad or Tamil Nadu, but then that patient goes with the classified NGN and all this score, and you have said that endometriosis classification according to that. If that patient goes with same document to US, let's say, okay, then a treating doctor in US also will understand that, see, what was the scenario. And how, see, because they don't have, we give CD or DVD or USB to that patient, but then 2 hours surgery, 1.5 hours surgery, nobody has time to, see that entire surgery. So definitely it has to be there. And proper documentation will help patient as well as us also, because then, see, patient will come back to us, let's say after 3 years. After that, this is fertility enhancing surgery. Let's say patient has again recurrence and comes after 4 to 5 years, that say I want completion surgery or such kind of surgery. If we have reported it very well, it will be better for us also to understand.
Okay. So the
Yeah.
other thing is when you incidentally find out totally an asymptomatic patient, you do a diagnostic laparoscopy and you see peritoneal endometriosis. So as surgeons, we excise the lesions. So what is your take on excision and ablative
I'm
procedures?
very much particular in taking consent. That is one. My single factor which I rely on is patient's complaint. Single most important factor. If patient is symptomatic, she will give you consent for resection anastomosis of the bowel also.
This is
If
not the
patient-
bowel, it's a
No,
peritoneal.
I'm just coming to that point. If patient is not symptomatic, she will not give you consent for even, cystectomy. So then it depends on for what patient comes to you. If patient came with the fertility, you treat only fertility. You have consent for that? No, you don't have. If you don't have consent for that, don't go for that.
So when you do a diagnostic laparoscopy, find a peritoneal endometriosis in an
No.
asymptomatic women, you don't do anything.
I'll not do anything.
Okay, because literature says stage 1, stage 2, if you treat it, at the time of diagnostic hysterolaparoscopy, it improves the
Right.
fertility outcome.
Right.
So,
But then
why-
if it is priorly discussed with the patient, that what we usually see is this is what MRI says, this is what we think. We may find something else also. So if you are agree, then we will go for some major part of surgery. If you do not agree, we'll stop there. So usually patients say that no, if I don't give consent, don't do anything. So it depends. If patient is not giving consent and there is no consent for anything, doing anything else, better not to do it. So I personally don't do it.
Okay, fine.
Mhm. Yeah, so it is, good. So very rightly said, unless and until it is consented, I don't think so. We should also, unless until, because if it is going to be an extensive DIE, we will, the patient will be definitely symptomatic and we would have consented for peritonectomy. Otherwise, for mild cases, just because you are having 2 chocolate cysts and you are seeing one nodule there, one bluish dot there, here and there, you don't have to, excise all those peritoneum.
Right.
Unnecessary dissection is also harmful. So that is well taken. And of course, NCN classification, universal language for all of us to communicate. So otherwise, everyone, what will be stage 1 may be something else for you. So that is the reason why these classifications have come up. And now they also have an app, I believe. So NCM app is supposed to be widely used. So again, also as everything is advancing, technology is advancing, our understanding of the disease is improving, and also surgical skills are also enhancing. So that is the beauty of this particular specialty. So thank you so much, Dr. Devan Jogal.
We have one question in the box, like if injecting vasopressin into the ovary and temporary vasoconstriction affect the AMH levels?
No, because the effect of vasopressin is hardly 19 minutes. So it is not going to anywhere interfere with the ovarian reserve or anything. So after 20 minutes, the effect is all gone. It will only enhance you to do this procedure very well. And of course, I believe in injecting vasopressin onto the ovary only because it gives me a very beautiful cleavage. So I have found that the cyst wall peels off very well, and also the hemostasis is well taken care. I don't have to use any cautery at all, and this is what I generally do. I don't inject on the uterus I inject right on the ovary, the cortex and the cyst wall. It doesn't matter even if it goes inside the cyst also. It
works out very effective.
Some amount of fluid there, it gives that space for us to, reset. So excellent. I think we had a very good session now. Let me just see whether the results are out. Yeah, so correctly, everything is as per time. So we have 4 winners now. The first one for the first talk, that is for the fibroid fertility sparing surgery. The winner is Dr. Sindhuja Somasundara.
Shall I display, ma'am?
Yeah, Dr. Sindhuja. Yeah, you can display. Yes, Dr. Sindhuja Somasundaram. She is from Erode, Tamil Nadu. She found the answer in 17 seconds. And for the second talk was on prolapse, right? No, the second one was Dr. Devan Jogal, actually. So that was that's been taken by Dr. Danya from Chennai. Okay, she got the answer in 7 seconds. And the third one, which was on ovarian tumors, fertility sparing, Dr. Joylene Almelda. She is from Mangalore. Good. We have people from various parts of our country. And then the fourth one, of course, which was by Dr. Sujal Munshi, that is on the prolapse. It was Shreya Kashyap. She is from Narsingpur, MP. So good. So it is very nice. So this is actually a great initiative by IAGE and Shield Pharma has sponsored all these prizes. So the concerned people will be receiving all these prizes from Shield Pharma either by their local representative or by courier. So thank you so much. I think it was quite a good session and we had a good participation also and great interactions. Thank you so much all the faculty for joining us, Dr. Sujal Munshi, Dr. Devan Jogal, Dr. Jayashree, and also our esteemed chairpersons, Dr. Vanita, Dr. Priya, and also Dr. Jayamala. So I would thank IAGE President Dr. Atul Munshi and the entire team for giving us this opportunity to do this webinar on this very important and interesting topic along with our local society, Oxy Endoscopic Committee. Thank you so much. We'll see you again sometime later. Thank you. Bye. I would take this opportunity to express my heartfelt thanks to Shield Pharma for providing us this excellent platform and also encouraging us with all these activities like the quiz and the gifts. Thank you so much.
Thank you, ma'am.
Bye.